Welcome to day 2 of the Nimhans Tavistock conference. We have got a lot of exciting topics and themes lined up for you today, and I'm sure it will be an intellectual feast for all of us. Without further ado, let me now invite Dr. Shalini NG, Assistant Professor of Psychiatry at Nimhans, to moderate the first session. Over to you, Shalini.
Thank you, Suhas. It gives me immense pleasure to introduce the chairperson of today's first session, Dr. Palomi Sudhir. She is Professor of Clinical Psychology at Nimhans. Her areas of interest are cognitive behavioral therapy, third wave CBTs, mindfulness-based intervention, and health behaviors in medical conditions. Over to you, ma'am. I request you to introduce the two eminent speakers of the first session.
Thank you, Dr. Shalini, and it's my pleasure to be chairing this session on medically unexplained symptoms and psychotherapy in persons with medically unexplained symptoms. Our first speaker for today is Dr. Julian Stern, and I would like to introduce him first and then go on to introduce Dr. Geeta just before her talk. Dr. Julian Stern is currently consultant psychiatrist and head of psychiatry at Tavistock and Portman NHS Foundation Trust. He is a trained psychiatrist and psychoanalytic psychotherapist. His areas of interest and specialization are in the applications of psychoanalytical thinking and clinical practice in medical settings. He's worked extensively with patients with medically unexplained symptoms and serious medical and surgical conditions. He's also trained GPs and staff in working with those with medical symptoms and medical conditions. He's published in his areas of interest in various journals of psychotherapy, psychiatry, gastroenterology, surgical and nursing journals. With respect to his training and positions, he's trained at Maudsley Hospital, London, as well as in adult psychoanalytical psychotherapy at British Psychotherapy Foundation. I think most important is that he has developed and headed the unique psychological medicine unit at St. Mark's Hospital, which is a specialist hospital for gastrointestinal disorders. He's also been the director of adult and forensic services at the Tavistock and Portman NHS Foundation Trust. With these words of introduction, I now invite Dr. Julian Stern to speak on psychotherapeutic approaches to patients presenting with physical symptoms. Dr. Julian Stern, please.
Well, hello everyone, and thank you very much for that introduction. I'm delighted to be here with you all. Thank you, first of all, for the invitation to me and my colleagues to participate in this meeting. To my friend and colleague, Dr. Dinesh Bugra, who was partially instrumental in helping bring our two institutions together. I'm looking forward very much to Dr. Geeta Desai's talk. And thank you both to Shalini Naik and Dr. Sudhir for your introduction. So I'm going to move pretty much straight on to describing a way in which I work. The title of the paper is Psychotherapeutic Approaches to Patients Presenting with Physical Symptoms, and there's a sort of subclause with reference to middle and old age. And part of the reason I add that is that increasingly, and perhaps it's as I get older, many of my patients are patients with physical symptoms who are in their middle or elderly years. I'm going to be talking to you predominantly about one case, the case of a woman called Ms. A. And then if there's time, thinking about some aspects of physical symptoms, dealing with loss as one gets older, and the challenges and defenses that are involved in this. But my clinical psychotherapy practice includes, with patients at least seen weekly, some more frequently, these patients, an 84-year-old man with a good marriage, struggling with a recent onset of sexual impotence, a 76-year-old woman who almost starved herself to death 10 years ago, and with significant guilt over a termination of pregnancy and abortion over 50 years ago that is still plaguing her. A 57-year-old man, a head teacher, a woman, with one teenage child who's still obsessed with having another baby by IVF and multiple aches and pains. A 55-year-old married man with triplets conceived by IVF and loss of libido. And a 44-year-old female model who struggles with her body dysmorphia regarding her nose and her ears. So as you can see, many of my patients that I currently work with are those with physical symptoms, many of which are what one could call medically unexplained. Now, Ms. A is a 76-year-old woman referred by a neurologist who specializes in headaches, who I know. And he said in his referral letter, "Dear Julian, could you see the 76-year-old unmarried woman, originally from Canada, who came to the UK when she was 20. She now complains of multiple unexplained pains throughout her body and headaches that keep her awake at night and do not respond to painkillers. She's a lovely, intelligent woman and very close to her cousin. Her cousin is a male doctor who comes to every medical appointment with her. I think she's feeling depressed," said the neurologist, "and possibly lonely, but she denies this. Anyway, I contacted her and she agreed to come and see me. She arrived on time and she's a well-looking, tall, 76-year-old white woman, very talkative from the start, and she told me all about her pains, her headaches, her problems with her heart, her problems with the digestive tract, and so on. And she told me for a long time about how important her life is. She's an important art dealer, a lover of culture, how she goes to watch dance and theatre and films every week. This is before lockdown. And how well known she is at the art galleries throughout London, and how she goes to many lectures and exhibitions every week. She told me about her friendships with famous artists, and I wondered about her. And why was she telling me so much about all of this? And indeed, why was she here with me? I found out a bit about her personal history. She was brought up in a small town in Canada, and there was much emotional deprivation. She was an only child. Her parents were very unhappy in their marriage. Father was an alcohol drinker, and it appears that mother never really loved him much. Mother wanted more children. He didn't, and so she remained an only child. And then when she was 6, father died whilst driving alone in a car accident, and she's often wondered, was this suicide? Her mother, who'd been emotionally absent, in her words, remarried a year later, and stepfather became violent, resented Ms. A for being around, and when she was 13 years old, he tried to abuse her sexually, but she resisted, and mother did not really protect her. She really felt she had no one to speak to. She had no siblings. She was academically excellent and won prizes at school, especially in literature and in art. And as soon as she could, she left Canada, came to London at age 20, studied in London, and founded an art business. It's been successful but hard work. She does some painting as an amateur, but never professionally. And she lives on her own, albeit with her beloved dog called Picasso and 5 cats who are all getting older and sicker. She said, I never trusted men. Her first sexual intercourse was at age 35 when she was inebriated with alcohol with a man who she was infatuated with, a married man who she continued an affair with until he died suddenly 10 years later. He never left his wife. He died suddenly of a heart attack, and she couldn't go to the funeral. On the day of his funeral, she developed sudden severe headaches and stomach pains, and she said she had to go to the hospital for an emergency checkup that day. And since then, she's had no intimate relationships. She's had no pregnancies. She cried. She said she never wanted children. She knew she'd be no good at it. And as I said, she's got 5 cats and an old sick dog. And she said, if Picasso dies, I may as well go too. She said to me, I wasn't expecting to get upset today. I hate getting upset. Are you going to tell my doctor that I'm mad? And I said, not mad, no, but sad. And towards the end of the consultation, this is the first consultation, she told me about a dream. I did ask if she had any dreams. And it was of coming to an appointment, to an office, and having to get undressed and take off her underwear. And in the room, there was just a young man laughing at her. It was awful. Now, my practice is very much oriented towards psychoanalytic psychotherapy. And so I both asked her for a dream and at least proposed a tentative interpretation. I said that I think the dream shows how much you feared coming here to see me, exposing yourself, and that instead of any care or sympathy, you feared you'd be met with something that felt terrible and humiliating, a man called Dr. Stern, who just laughed at you. She agreed and said she was very anxious about coming to here, and it's only because she trusts her neurologist that she agreed to come. She went on to tell me about her cousin, who is a younger doctor. This cousin doesn't believe in psychotherapy at all. He just thinks she should have more and more special investigations on her headaches, on her gut, on her physical symptoms, until something is found. I said, there is a part of you that knows there are things to be explored. Your loneliness, your fear of growing old. But there's another part of you that just wants to push these problems away, like your cousin does, and just wants to focus on the physical symptoms. That's the part of you that doesn't believe in psychotherapy. And she nodded. I wasn't sure how much she'd taken in. So, there was one dream interpretation, and now another interpretation that spoke to splits within her personality and the question of denial. I said, as I've just told you, that there's a part of you that knows there are things that need to be explored, and there's another part of you that would prefer to deny them and push them away. Towards the end of this first appointment, she complained of a headache. Then she asked if she could go to the toilet to urinate. And then she returned to my room and told me she must see me again soon. Please, I know I've got little time left. I need to explore these issues. I offered her a follow-up in 2 weeks. She thanked me and left, seemingly very grateful, and she took about half a box of tissues from my tissue box as she left, saying she needed them for her trip home. After the first appointment, I thought I'd made good emotional contact. I was aware of some of her defenses, the need to build herself up into something big and powerful. I was aware of her need to focus on physical symptoms rather than emotions, and of her bodily symptoms, how her headache and her need to urinate had intruded towards the end of the session, something that needed to be evacuated from her mind and her body. But I thought that there was an adult part of her personality that was able to stand back and say, look, even if this is going to be painful and messy and sad and disappointing, even if it makes me angry with my parents or with myself, I do need to explore this. Now, I thought that there were a number of positive indications for therapy in this case. And if we just look at an American author, Glenn Gabbard, who's come up with a list of 11 criteria as to who might make use of psychotherapy, I know that these criteria in some senses are rather artificial, and you can have them in the slides afterwards. Does she have a strong motivation to understand? I was unsure. Is there significant suffering? Yes. Is she able to regress in the service of the ego? I was unsure, etc., etc. And finally, number 11, was she able to respond to trial interpretations? I thought probably. And so I was expecting to see her back in 2 weeks' time. I never saw her again. She emailed me. She complained she never knew it was going to be so psychological. Not sure what she thought she was going to get when she saw a psychiatrist. She thought I would just focus on her pain. She's discussed the matters with her cousin, the doctor, who completely agrees that she is the most stable and healthy woman that he knows, and she prefers never to see me again. And she says she will write a letter of complaint to the original neurologist who referred her to me. Was this outcome predictable? Well, there's been a lot that the first meeting evoked in her. The loss of actual people, deaths of potential people, friends, partners, perhaps even children who she's never had. It made her feel vulnerable. It made her feel lonely. And it made her feel small. And in some ways, I think that her response represents what Melanie Klein, well-known British psychoanalyst, called a manic solution, a set of mental mechanisms designed to protect the ego from depressive and paranoid anxieties. The three constituents are omnipotence, denial, and idealization, and I think we perhaps see them all in this case. I am big. You are useless. I will bring you down to size, is omnipotence. Remember how she boasted in the first few minutes about how important she was, perhaps hoping to make me feel relatively small. A denial of her losses, and then an idealization by her relative of how stable she was, and by herself of her own cultural activities. But it did all feel rather thin. Now, there are many losses that one has to face in middle and old age. I've listed some of them: the loss of people, the loss of bodily functioning and physical capacity, the loss of identity, of potential, the loss of denial of immortality. As one grows older, it becomes more and more difficult to pretend that one is immortal. Losses of a material nature, and the loss of a child in some cases. And she's suffering from many of these losses and is choosing for the time being to deny them and to motor on, and perhaps to get help by focusing on her physical symptoms rather than on emotional symptoms. Freud was rather pessimistic about the possibility of working with people anything above the age of 50. But Erik Erikson, who some of you will know well, postulated a theory of developmental stages. Each of his stages has a name and age range and a task. Stage 7, mid-adult, 40 to 65, is entitled generativity versus stagnation, and his final two stages are those of mid-adult and older adult. In each stage, there are developmental tasks, and in each stage, one can either overcome them or resolve them successfully or not. Here is just a graphic representation of his 8 psychosocial stages. And he describes how in middle adult stage, the individual's main concerns are being their career and their family. The social task here is generativity versus stagnation. And the inability to master these tasks may result in feelings of stagnation, as though one is not leaving a mark on the world in a meaningful way, and sometimes feels little connection with others and little interest in productivity and self-improvement. Now, I couldn't give this talk without referring to a close colleague and friend of mine, who of course hails from your home country, India, Salman Akhtar. And he's written a lot about these issues, including what he calls someday and if only fantasies. Akhtar wrote about those with a secret hope that someday all of their problems will vanish, or they'll be strong enough to deal with them. They have a kind of expectation from themselves and from their analyses, if they're in analysis, from life in general, that they put things off, never finish things, withdraw when things get too tough. But someday there'll be a time when they'll be completely peaceful and conflict-free. Everything is available, even thinking is not required, and there is no aggression from inside or outside. The if only fantasies are those individuals who insist if only it had happened or had not taken place, then everything would have turned out all right. Life before the event is idealized, their intense nostalgia with a wish to recapture the idealized past. Both of these someday and if only fantasies involve splitting, denial, primitive idealization. Both serve defensive purposes, and both can be described as fantasies of ideal times. He says they sometimes co-occur. If only this had not happened, life would be all right, but someday this will be reversed and life will again become blissful. And of course, if one lives one's life too dominated by someday and if only fantasies, one will end up disappointed. Now, I know I've only got a few more minutes left, and after the conference, there will be the opportunity for me to share some of these slides with you. So I just want to focus again on clinical work, a man who was able to benefit, Mr. A, and just in the last few minutes tell you about him. I did see him for 9 sessions sporadically, and then for 6 weeks in a row. He's a retired banker who was referred to me by a professor of gastroenterology. He described his pains, his abdominal pains that were just impossible to shift. When I get pain here, he said, it's severe, it makes me depressed, I have to cancel holidays. When pain is tolerable, I'm okay, I enjoy life, and I am energetic. And the story of Mr. A is that he's plagued with guilt over the last 30 years for a stillborn child that his wife had, and he feels responsible for it. He was working in Central Africa. His wife did not get to hospital in time. The baby was stillborn, and he feels he's never been able to grieve properly. And as a result, he's been left with chronic, intractable abdominal pains. By the end of the 9 sessions of psychotherapy, and I'll skip through some of these slides, we got to a final session. He had developed a migraine as he is coming to see me. Normally, these occur no more than once a year, but they affect his thinking and his seeing. I said I thought he was showing me that he had ways of ensuring that he did not see or think about things, especially the fact that our sessions were coming to an end. He agreed and told me how much better he was after these 9 sessions. He no longer cancelled anything because of pain. He's talking in a different way to his wife and his daughter. I asked him if he was anxious about not seeing me weekly after these 9 sessions, and he said he hoped he could continue building on what we had done, and he wondered why he had resisted seeing someone for so long. He said psychosomatic implies malingering or making things up, but the pain is genuine, and he'd needed help years ago. And towards the end of the final session, he told me he'd been thinking about his education. He'd had an expensive education, but he had not been educated. I said I thought he was telling me about an emotional education and about making links and feeling things and the work we'd started together. He agreed, and he told me what a struggle adulthood had been. He thanked me again, saying initially he'd found my style too unstructured, that I'd not asked enough questions, but he now recognizes the value of him gradually setting the agenda and bringing material up that's on his mind. I've heard from his physicians they think he's doing very well. His pains are almost gone, and he's appalled at the thought of any more surgery, and he wonders why he even put himself forward for previous operations for functional bowel disorders. So, in conclusion, I've described 2 patients, Ms. A, who was unable to make use of therapy, and Mr. A, who could make use of some therapy. Physical symptoms appear at all stages in our lives, and sometimes they do offer an opportunity for someone to receive psychotherapeutic help, even if they were not anticipating that as an outcome. A close relationship with our colleagues who work in medicine and nursing renders this possibility more likely. Thank you very much for your attention.
Thank you, Professor Stern. And I think we'll take questions at the end of both the speakers' presentations. I'll now go ahead and introduce Dr. Geeta Desai, who's the next speaker. And while Dr. Geeta is presenting her slides, bring up her slides, Dr. Geeta will be speaking on cultural and ethical challenges in psychotherapy in persons with medically unexplained symptoms. Dr. Geeta currently holds the Professor of Psychiatry, designation of Professor of Psychiatry at the Department of Psychiatry at Nimhans. She's also a consultant at the Perinatal Clinic at Nimhans. Her areas of specialization include somatoform and related disorders, chronic pain, and perinatal psychiatry. She's published extensively in the areas of somatoform and related disorders, chronic pain, and perinatal mental health. And she's also conducted workshops in the areas of chronic pain. Dr. Geeta, over to you.
Should I turn off my video?
Turn off your video.
Good afternoon, everyone. I hope I'm audible. So you've just heard Dr. Stern speaking about psychoanalytical psychotherapy for patients who've had MUS. So I'm going to take a little deviation from the concepts of psychotherapy in patients with medically unexplained physical symptoms. So let me begin with why I became interested in this area. So I'm going to talk to you about, I think many years ago, I'd seen this lady who was 30-year-old and who came for a consultation. And she had actually seen a neurologist who's felt that, there was nothing wrong with her. And then they had referred her to for psychiatric evaluation because she was not able to sleep. She was just 30-year-old, and then she had something very unusual that we see very often in Indian population. That was half body pain, but it's not an anatomical distribution, just right half of her body. She said that she had a lot of pain, and it had increased in the last 2 years. And on exploration, we found that she had undergone hysterectomy at a very young age. She was about 28 or 27 at that point of time. And when we discussed about what could be the reason why she had undergone hysterectomy, she said that she was suffering from, I'll use the terms that the lady actually mentioned. She said she had been suffering from white discharge per vagina, which was causing a lot of distress to her. And so she had undergone evaluations. And then she said that since she had completed her family, and this could be the reason why, so she agreed to undergo a hysterectomy with the belief that her symptoms would go away. So then for a few weeks post hysterectomy, she said that she was feeling better, but then the pains came back. So post that, she's been visiting multiple doctors and physicians, has undergone a lot of investigations, including CT brain, MRI brain, but there was no respite. So she was very distressed about her pain. And so when we, spoke to her in length about what were the aggravating, relieving factors, so she said that she couldn't identify any aggravating or relieving factors. What was interesting also that she did not report of any illness-related fears. She did not think that she had any, worries that she could be suffering from cancer or any other illness. Her distress was predominantly related to her symptoms. And she said that all the problems have happened after her, consultation started because there were a lot of financial difficulties. So we tried to, next step was to ask her about emotional states. And then she kept bringing back pain as the main symptom, but she was not really saying that she was sad. But what she kept saying is she was tired of her symptoms. There was no respite for her. And this was, since this hospital is like a tertiary care center. So she said, this is my last option. If I don't get better, I think I should, end my life. So that was the kind of scenario that she had come in with. So what I would like to do is, I think the concept of medically unexplained physical symptoms itself, she came with the right half, body pain. So I think these are very common symptoms. They are there everywhere. They are across specialities. They, they can be a single symptom or multiple organ systems. And even though we do not, try and use medically unexplained physical symptoms any longer, but as we all know, there are somatoform, somatization, functional somatic syndromes. So multiple nosology, nomenclatures have been used for this. These symptoms are the so-called described that they're comorbid with depression and anxiety. They're associated with health anxiety, illness behaviors, as well as alexithymia. The reason why I thought I should put these up is because all these aspects are taken into consideration when therapy is being planned. Now, to understand for the interest of psychotherapy, what are the features? Most commonly, they are diagnosed in women who come from low-income strata from developing countries. And it's also recognized that women tend to experience these symptoms because probably it's easier to seek help for physical symptoms than the emotional symptoms. Now, if you look at the original description of what somatization constitutes, it's a very, very simplified form communicating emotional distress or psychosocial distress through bodily symptoms. Would that mean that these people who experience bodily distress disorders have no words for emotions or emotional states? Because most of the psychotherapies we discuss about feelings. So if they do not have words for emotions or emotional states, so what are we looking at? Now, earlier studies had kind of mentioned that, these symptoms much more common in particular cultures, but we know that now somatization or medically unexplained symptoms are culturally universal. They're also considered as cultural expression of idioms of distress. Now, why is this important? Even though we've said that medically unexplained physical symptoms do not have a diagnostic category other than somatic symptom disorders, but they are idioms of distress. Now, what is an idiom of distress? Basically, it's a cultural expression of distress to elicit a particular social response. Now, why is it that, there are lots of discussions about how we understand medically unexplained symptoms? Because it's very important for us to know how we plan our interventions. I think Lawrence Kmeyer has written extensively about culture and medically unexplained symptoms. So probably they are better understood when placed in the cultural context rather than in a medical context. We all know the pain, the word pain probably is much more easier in English, but there are multiple words in different languages. So if the person is communicating the distress in their own subjective experience, in their social and cultural context, how we interpret, how the physicians interpret on the other side of the table is very, very important, because the act, like I described in the first case, I think the explanatory model in that lady was that she felt that white discharge per vagina was the main reason why she was experiencing so many bodily symptoms. But if that is misunderstood from the other side, when I say other side, from the physicians or the treating, so the interventions are likely to be problematic. So why psychotherapy for patients with medically unexplained symptoms? So as we know that none of the guidelines actually prescribe pharmacotherapy as a first line of treatment for medically unexplained symptoms, unless there is a comorbid anxiety or depression. But the real world scenario might be very different, where because they come in and I think they come in looking for a prescription, probably that's what they get. So if you look at efficacy of pharmacological interventions is actually limited. There is very, very limited evidence for its efficacy. However, there is also a debate about how psychotherapy could be the main treatment modality for MUS. Now, what are the psychotherapeutic treatments that have been that have some evidence that are probably being considered? So these are some of the psychotherapy interventions that have evidence. Like, for example, cognitive behavior therapy has good evidence. When I say good evidence, but the meta-analysis actually kind of said low to moderate evidence. Now, one need to understand, especially when we talk about RCT. So, we need to critically look at who are these people who are included for CBT or mindfulness-based CBT, acceptance, commitment, and psychodynamic attachment-based therapies. But for all these thoughts, addressing thoughts and emotions is a slides. Okay, I can see here.
Share screen will have to share.
So just keep talking.
You talk.
Okay. Yeah. Sorry for the interruption. So there are different types of therapies that I have put up. Now, I'll tell you, as a clinician, all these therapies we need. So addressing thoughts and emotions is very, very important in all these therapies. Now, the biggest challenge that we face when we see women or patients who have medically unexplained symptoms is when they come in with the notion of an organic model or a medical model. And what we are trying to convince them is that it's not the problem in the body, but it is the problem in the mind. So somewhere we are taking the focus away of when they are focusing on the body, we are focusing on the mind. So that's the first step that is a challenge for us, because you need to shift the change. Now, I'm sure we are all aware of reattribution therapy. It was kind of, suggested as one of the important therapies, but it's not as simple as that. Okay. I can't see this. Yeah. So engaging patients in psychological interventions is a challenge because of their explanatory health and illness beliefs. Now, to even before pre-treatment factors are very, very important before engaging them in psychological interventions. I think Dr. Stern actually alluded, the resistance that is seen in patients who are referred to a psychiatry. Now, what are the predictors that have been included, that considered necessary for a good outcome for psychotherapy? One is motivation and openness for psychotherapy. There are very interesting studies which I've looked at. I think one is from Turkey, where they looked at, comparing Turkish migrants in Germany and the population there, native population, and they felt that the motivation for talk therapy or psychotherapy was very poor. And openness for psychotherapy. Motivation and openness is also about exploring the problem as well as, looking at the suffering, addressing the possible factors related to self. Now, that's a big predictor, but what studies have found is motivation and openness for psychotherapy might be a challenge. There are cultural norms and values influence specific attitudes and beliefs about illness. So if a person believes that there are certain reasons why they are suffering from these physical symptoms, and they are trying to convey the same in their milieu, so it may be difficult for the health professionals to intervene at that point of time. And more often, patients with MUS are looking for external cause and less towards self. And most of the psychotherapy, we try and make them understand, introspect, or understand and how their own factors could be contributing to them. The other area that I always find it interesting is empathy in persons with MUS. Because as I mentioned about alexithymia, they have difficulty in emoting, but it is also known that empathy in neuroimaging studies have demonstrated that there are issues related to empathy in persons with MUS. And would that affect the therapeutic alliance with patients who work with MUS? And I think there's a good debate about if somatizing is a problem, is psychologizing is also an issue? Are we over-psychologizing what the so-called cultural norms of expressing distress? I think that's the point that we need to also think when we adapt certain interventions from different cultures. The other barrier or a challenge that would be interesting is understanding the language. Often nerves, the so-called nerves, are not used in the similar way. Many of them interchangeably use it for veins. They talk about how they have nerves beating or swollen nerves, which can be interpreted differently by the health professionals. And so these are the questions. I mean, I think after going through many of these therapies, these are the questions that came into mind. When a person is expressing through body, should we focus on mind? Or should we intervene through the body and then address the mind? And I think, the last question, that challenge that is, are we making them more sick than they are by addressing conflicts and many other emotional issues? Probably is somatization a defense that didn't allow them to address their emotional problems. It's not moving. Excellent. Okay. So there are a lot of interventions. How am I doing for time? There are a lot of discussions about how in culture, how mind and body are discussed, whether the dualistic nature or is it, considered as a holistic. So there is a lot of emphasis that Westerners look at it as mind, body, as a dualistic nature and Eastern. But of course, I think things have changed a lot now. But what I would want to emphasize is, I think most of the interventions that I mentioned are mind-body interventions. That means you address the mind first and then it affects the body. But is it time that we started looking at body-mind interventions? Because, that would probably be more acceptable. This is my conceptualizing body-mind interventions as, you focus on the symptoms and then address the mind-related interventions. Now, when we talk about psychotherapy and how to incorporate the cultural aspects, there's a very interesting paper by Seng in 2004, where describes about 3 components that we need to take into consideration. One is the technical adjustments, the second one is the theoretical adjustments, and the third one is the philosophical adjustments. So when I say technical adjustment, it's all about how the patient health professional relationship. Because I think CBT needs a lot of collaborative work, but we all know that in some setups, health professionals are supposed to take more active role and more at a probably in a hierarchical fashion. They might be at the upper hand where they are supposed to give suggestions, which might not happen with other forms of therapy. That's about, there are many other age, gender, some of these things we need to take into consideration. Theoretical adjustments is like I mentioned about, understanding about mind-body, how is it in each culture recognized? How is the concept of self in each culture? That needs to be taken into consideration. Now, philosophical adjustments, I think, especially in people who suffer from chronic somatization, addressing spirituality, addressing the, sometimes it's about, talking about, there is something called karma in Indian. Okay. So I think it's important we understand these, sometimes attributing their suffering to an external cause could actually bring down their own sense of burden. And hence, I think it's important for us to consider these aspects in psychotherapy. I would also like to, highlight a paper by Erna Hawk, which I think Dr. Murli yesterday mentioned, about a single session. One of the main challenges of administering psychotherapy in our setting is also about the number of sessions, the need to come and see the therapist as often as possible. So I think many would not agree to do this. So there is a single session probably is something that needs to be explored. So there's a very interesting paper on how actually one session can make the change. And it's not about just reattribution therapy. Okay, so this is about culture. And I basically have spoken about how culture can be incorporated into psychotherapy in individuals with MUS. Even though there's a lot of discussion about how culture has a role in idioms of distress and, in terms of understanding MUS, but research in terms of therapy, psychotherapy with MUS is very limited. Now, the other aspects that often concern me is we are treating the unknown because we don't know why these physical symptoms, but we have certain hypotheses on why this is happening. And often talk therapy may not sound as a treatment in a medical jargon. And by making the person with MUS talk about their emotions, are we changing the core way of how distress is being communicated? And I think it's high time we also talk, if single session therapies work, then what happens to long-term therapies? So these are some of the ethical challenges that I thought I will bring in. So just want to say that even though there's a lot of evidence for many of these therapies, but implementation and using these therapeutic modalities in different cultures still appears to be a challenge. Thank you.
Thank you, Dr. Geeta. And there are a few questions that have come up, and I think we had a very clinically enriching presentation by both Dr. Stern as well as Dr. Geeta Desai. And I think the case vignettes really brought out both the challenges as well as the difficulties in working with these clients, as well as what perhaps stance the therapist may have to take. So I'll take the first question, which is to Professor Stern. Let me just read out the question. The first question says, can we say it was also transgenerational impact of abandonment fears in Mrs. A? And Mrs. A's trauma was replicated through her mother's, let me just see. Mrs. A's trauma was replicated through mother's trauma in her inability to form an intimate romantic relationship, and her own experience of death of her father and her partner seemed to reinforce her fear of abandonment. Thus, she associated herself similar to her mother in terms of relationship losses. This is from Kanika, Faridabad, and this is to Professor Stern. It's a rather long question. Professor Stern, you're on mute.
Hi. Can you hear me now?
Yes, yes.
Good. I couldn't have put it better myself. I think that our colleague has really described so much that I hope would come through. The sense of emotional impoverishment from an early start, probably growing up with a relatively depressed mother in a hostile relationship, the possible death of a father by suicide, and one always wonders, was I not important enough to my father or my mother that they wanted to remain alive? The mother pretty, thinking very much of herself, remarrying very quickly to a man who had not only no real interest in this daughter in terms of wanting to be kind to the daughter, but then as she becomes a teenager, expressing an incestuous and pedophilic sexual interest in this daughter. So she really found her refuge in 2 or 3 different ways. The one refuge was in becoming very good academically. The other refuge was in literally leaving her mother as soon as she could and coming to what she hoped would be a more welcoming environment, which was the UK in her case. Now, yes, environments can be more or less welcoming, but one doesn't necessarily sort out one's personal issues just by moving country or moving city. As many of us know, if we have moved country or city, it still requires further psychological work. And unfortunately, what she chose was to prioritize very much her professional success, but at the expense of sorting herself out in any way socially and emotionally. So she was very phobic of intimate relationships. I think it's interesting, and she's not the first patient who was only able to have any form of sexual intimacy when she had essentially used alcohol to relax her, and one could argue to diminish her sense of guilt, her sense of anxiety, her sense of fear. Somebody once described alcohol sometimes as a solvent of the superego, by which they meant it sort of dissolves some of one's fears and guilt and anxieties and allows one to do something that at least a part of one does want to do, which in her case was to have an intimate and sexual relationship. But it's interesting that she chose as her partner an unavailable man. a bit like her father, a man who was already married to someone else and who never left his wife, albeit during the 10 years that they were having this sexual relationship, Miss A and him. So questions of intimacy, of psychosexual development, of abandonment, of trust are absolutely permeating this lady's case material. And of course, what she, as it were, chooses to present with, and by choose, I'm putting it in inverted commas, she chooses to present with physical symptoms. And as long as one goes along with investigating the physical symptoms and doing x-rays and scans and scopes and investigative laparotomies and so on, she can handle it. When you choose to investigate her using a different sort of scope, which is sort of the psychoscope, looking into her psyche, examining, exploring, challenging her, she flees and she challenges one and says she never asked for it, she doesn't want it, she can't cope. So yes, the comments that your questioner has raised are absolutely spot on. Thank you very much.
Thank you, Professor Stern, for that response. The next question is actually for both of you, and I request Dr. Geeta to first come in to respond and then Professor Stern. The question is, any advice about the counter-transference a doctor develops when patients with psychosomatic disorders do not show any improvement? Dr. Geeta?
I think it's very important because these are patients who are labeled as being difficult or probably difficult, stigmatized. So at the outset, I think it's important as health professionals to examine our own feelings on how comfortable we are in dealing with them, and also in terms of what are our goals. Especially dealing with someone with MUS, is it that we are looking at reduction of symptoms? Is it reduction in distress, or is it the complete disappearance of symptoms? And I think when the therapeutic alliance is there, I think it's important to keep re-examining goals and methods that are being used. One option could be that you could actually have a diary where there are frequent exacerbations and go back and see what could be the potential reason. There's also the other aspect could be that there is a possible change in the modality of treatment that might be required. Maybe sometimes we often start with CBT, but then we know that it is not really helping and we might have to change approaches. I think that's the strategy that can be done. If possible, if you feel that the professional feels that it's very difficult to carry on or feels defeated, then it may be necessary to have another therapist or different mode of therapy given by someone else may be a important thing.
Thank you, Dr. Geeta. Professor Stern, your response?
Sure. Well, thank you very much, Dr. Geeta. And just to say that, much of what you said, both in your talk and in your response, is very much in line with much of my ideas as well. And I particularly thought that it was important for you to put cultural considerations very central in much of what you said. So thank you for that. From a psychoanalytic viewpoint, I am always interested in what is evoked in me, in the professional involved in any relationship with a patient. And so when one feels that one is with a patient who's showing no improvement, perhaps the countertransference that is often prevalent is one of frustration, impotence, and sometimes even a wish to punish the patient. Now, as a psychotherapist, one can deal with those feelings, hopefully, by recognizing that they might be saying something about the patient and about their previous experiences in their lives. But also one can recognize that if there are feelings of impotence and a wish to punish in the hands of doctors or surgeons, that can be really scary, because a surgeon who is feeling impotent often has only one solution, And I'm thinking of a surgeon who is confronted with a 26-year-old woman with a white vaginal discharge, who isn't getting better with the tablets that he might have prescribed, and who basically thinks, well, there's only one solution, I'm going to cut your womb out. Now, hysterectomy, in my understanding, is not prescribed as a solution for white vaginal discharge. And one has to wonder, what was it in his countertransference, or assuming the surgeon was a male, but it might have been a female surgeon, what was it that meant that they moved from treating a patient with a white vaginal discharge to cutting her entire uterus out, plus minus her ovaries as well? And one can only imagine that for this woman who you described at the beginning of your talk, Dr. Geeta, one has to wonder what was going on in her life and what was going on between her and the surgeon. Who wanted the hysterectomy? Did she want it? In which case one has to wonder, why would an otherwise healthy 26 or 27-year-old want her womb cut out? Has she got terrible feelings of guilt or shame or something like that towards her gynecological organs? Does her husband want her to have a hysterectomy and that she opposed it, but she still went ahead? Or did the surgeon want her to have the hysterectomy? But something went terribly wrong. And this is what needs to be explored, because she is now left protesting, upset, possibly suicidal, because something has happened which probably repeated an earlier trauma over which neither she nor the surgeon had full information or were fully conscious of, and yet a terrible tragedy has occurred, leaving her, as I say, feeling suicidal. So to go back to the original question, what does one do about one's own countertransference? First and foremost, one needs to recognize it and not act on it.
Thank you. I think we have a lot of questions. I don't know if we'll have the time to take all of them, but I'm going over to question 4, which is a question on, in case of somatization, how is the choice of somatic symptoms determined?
Hello?
Just randomly? How is the choice of somatic symptoms determined? Or do the symptoms have some metaphoric associations with unspeakable, unexpressed emotional distress or psychosocial associations? Dr. Geeta, would you like to take this question?
Yeah, I think it's a good question. Most of the earlier psychoanalytic literature actually talks about symbolism of a particular symptom, but even in cultural explanations for somatic symptoms, they do appear that, the organ that is chosen is...
Sorry, I missed that. Can you repeat that question? I missed it completely. My technology failed.
It's the choice of somatic symptoms. How are they determined? Do they have some metaphoric associations, either with the unexpressed distress or psychosocial associations?
And am I lucky in asking Dr. Geeta Desai to respond, or was it addressed to me?
No, she's responding.
Okay. I think just talking about symbolism as well as part of psychodynamic psychotherapy, but the second aspect is about cultural meanings of these symptoms. I think it's more to do with the psychosocial milieu or cultural milieu, because particular organs have a particular meaning, and also, like for example, GI disturbances are associated with particular foods as well as particular emotions. So in that sense, I think it is important to understand, explore the meaning of these symptoms.
Thank you, Dr. Geeta. I think if we can't take all of the questions, they can be taken up at the panel discussion later on as well. But I think this one question is about, how do you feel trying to explain medically unexplained symptoms in terms of physical symptoms than mental? As Dr. Geeta Desai pointed out, affects the focus of mental health professionals on normalizing the expressing experiences and focusing on improving socio-occupational functioning and thus on clinical outcome. Again, it's a rather long question. So it's about how you explain MUS in terms of physical symptoms than mental.
If I can just respond briefly,
Sure. Yes.
I think that by far the most important thing when working with a patient who presents with MUS is to see if one can establish some sort of therapeutic relationship with them. And the first thing that I've learned is to take their symptoms seriously and to hear about the symptoms in their own words. If they suspect that you, as a psychologist or psychiatrist, are going to immediately expect them to be able to say, oh, the headaches aren't really headaches, it's that I'm depressed about a premature death of a parent or something, you will lose that patient within a few minutes. And of course, the pain that they feel, whether the headaches are due to a functional problem or brain tumor, the pain is very real and one has to absolutely acknowledge that. So I spend a lot of time in my initial consultation just hearing them speak about the pains or the symptoms or the discharge or whatever in their own words. Sometimes the use of their own words allows one to pick up on a particular phrase that they might use, which might have a double meaning. It relates to the question of symbolism and metaphor. I think that in the early days, some psychoanalysts thought that there was almost always a very particular reason why a particular patient would develop pain in their head or pain in their belly or pain in their arm, and that there would almost always be some sort of deep symbolic meaning to that. I don't necessarily feel that that is always the case. Sometimes it is, in which case it can be very helpful. And on one or two occasions, one of the most interesting things that happened to me in my work was working in a hospital for colorectal disorders, where some patients started with severe pains in their digestive tract or in their bottoms, in their anuses, in their rectums, and so on. And after working with me for a few sessions, the pain in the bottom seemed to disappear and they developed either headache or ocular pain. And I could then say to them, well, it now seems as though at least you know that the pain is to do with thinking about things or seeing things that you've chosen not to see in the past. But that takes time. And one of my concerns about a single session, although I recognize that, of course, resources are limited, perhaps especially in India, but also in the UK where we struggle. The problem with a single session is that sometimes one can feel one has a sort of almost cathartic experience with a patient where they suddenly start feeling better, making links between their pain and certain things that might have happened. But one has no possibility of following up and seeing whether that improvement is sustained or whether it relapses very quickly.
Thank you, Professor Stern and Dr. Geeta Desai. I think we've really run out of time now. There are a couple of more questions, and I think Professor Stern's last point actually partially answered another question as well on, change of symptoms, resolving of one and leading to another symptom. I think we could take those questions in the panel discussion. I'd like to thank both the speakers for a very enriching session and answering a lot of therapeutic challenges in clients with medically unexplained physical symptoms or persistent physical symptoms, and also to the organizers. And I will sign off here. Thank you.
Thank you, ma'am.
Thank you.
Now, may I invite Dr. Jayant Mahadevan, Assistant Professor, Department of Psychiatry, Nimhans, to moderate the next session, which is going to focus on technology and telepsychotherapy. Over to you, sir.
Thank you very much, Suhas. It's my extreme pleasure to introduce the chairperson for today's session on telepsychotherapy, Professor John P. John. He's Professor of Psychiatry at Nimhans. His area of clinical specialization is general adult psychiatry, and his research interests including linking multimodal brain imaging techniques in understanding the neurobiology of schizophrenia, dementia, as well as different cognitive states. He also has a very active interest in the psychotherapy program, and he's the faculty in charge of the Multimodal Brain Imaging Analysis Laboratory, as well as the Center for Brain Mapping and the ADBS Neuroimaging Center at Nimhans. I invite Professor John to take over the session, and sir, over to you.
Thank you, Jayant, for this warm introduction. It is indeed my pleasure to chair this session, this final session of lectures at this conference titled The Role of Technology in Interventions. In the late 1990s and early 2000s, one would sporadically see journal articles with titles such as Role of Technology in Psychotherapy, or the future of psychotherapy in the technological era, and so on. As years passed by, these articles increased in frequency. And suddenly, with this COVID-19 pandemic, we realized that the future is here. And the integration of technological advances with psychotherapeutic techniques is perhaps the most critical issue facing practitioners in the field. So therefore, this session is of great practical significance for all those who practice psychotherapy. And to handle this topic, we have two bright young psychiatrists, Dr. Amit Malik and Dr. Arun Kandasamy. The first speaker, Dr. Amit Malik, is the founder and CEO of Inner R, which is a startup that is trying to reduce the gap between the mental health care providers and patients by providing therapy and consultation online. Dr. Malik's area of interests and specializations include geriatric psychiatry, liaison psychiatry, technology in mental health, management and leadership in mental health. He has won several awards and fellowships, including the Young Psychiatrist Scholarship of the European Psychiatric Association, Clinical Excellence Awards by Southern Healthcare NHS Foundation Trust, Young Psychiatrist Fellowship by WPA, Award for Medical Student Teaching at Nottingham Medical School, etc. Over to you, Dr. Amit Malik. Are you muted? It looks like you might be muted. You want to unmute yourself? Okay.
Yeah, thank you. I was just saying thank you, Professor John. And great to see some familiar faces. Julian, Dinesh, thanks for having me here. Let me just share my screen to make sure technology works, because otherwise that would be too ironic. It didn't. Right, perfect. So listen, I've got 10 minutes. So what I'm not going to give you the entire detail of the technological landscape. As Professor John alluded, that has become very, very wide in the last 5 or 7 years. What I just want to do is drive home a couple of messages and give some examples and leave you with that, so that is starting food for thought, right? So the driver for technology, if you think about it in mental health, has been around for decades. And that's really thinking about the treatment gap in mental health that WHO has talked about extensively, and where the resource gap, the traditional resource gap between human resources, psychiatrists, psychologists, beds, clinics, and the number of people who need support exists. Right? But we all who've been in active clinical practice for the last few decades fully know that the gap is not just about resources. The gap is also because other barriers like stigma and awareness also create gaps in access to services. So what I've done is I've looked at in the last 6 years. So briefly, my background, Dr. John talked about it, but I've looked at technology quite deeply in the last 6 or 7, maybe about 8 years, since 2011, 2012, both in the UK and here, and just looking at how technology can be an enabler and what the different models of care are. But just to reemphasize the point that Professor John was making, the landscape has changed dramatically, right? Just this one article that I looked at from a outside-in perspective, right? Instead of looking outside as a psychiatrist and seeing what's happening in the world outside, looking at it from a perspective of the investment world and saying, what is happening in the technology-enabled mental health world? There are about 700 funded startups in the world right now in mental health alone. Right? And that number has spiked exponentially in the last 5 years. Now, if you go back to a decade ago, there were about 5 or 10. Now there are about 700 plus startups in the mental, and there are different types of startups, right? And a lot of money is going in. And those of us who are in India right now fully know how budgets are constrained, both in the private and public sector side in mental health. But about $4.5 billion has been invested in mental health and technology, especially over the last few years. So what are different models? The first model we've all talked about, and I won't spend a lot of time at all about it. It is the idea of doing therapy and even psychiatry sometimes online, right? In the jurisdictions that allow it, doing telepsychiatry and telepsychology online. This is a model we are all familiar with. So I can just move on from this one quickly, right? So, and we know the advantages. It's convenient, it's remote access. The validity of online CBT is getting established more and more over a period of time. Limitations remain that it doesn't work in all clinical conditions. It doesn't work in all clinical settings, and interpersonal rapport can be a challenge sometimes. But when you start looking at other areas, right? So the other point I want to make is that in my experience, and when I worked at the Royal College and other places, my experience was that there was a lot of debate around evidence base for using technology, right? And the one big comeback from us as psychiatrists is to be that this is still too early. The evidence base is poor. What's transformed in the last 5 years is that people in the technology world have realized that, right? So now, whilst the evidence base is still evolving, there's definitely a push to build science along with technology. Right? So people are looking at building the evidence base as they move along. So what I'll just show you is some snippets of these large providers in each type of model. So like, for example, in teletherapy, BetterHelp is probably one of the biggest providers. And there is some evidence base around their interventions that they've developed as they go along. I am not by any means saying that they've reached the gold standard of science in any of these modalities. But what I'm saying is that now people who are developing technology are also spending money, resources, and energy in developing the evidence base as they go along, right? So this is an example. The next model is really looking at online peer support, right? There's a growing body of evidence which we already knew in the offline space that group work, group therapy, group support has helped in recovery and relapse prevention. That same modality is continuing now into the digital world, right? And I've just named a couple of the large players in the space: 7 Cups in the UK, together all in the UK, in the US, together all in the UK, and just looking at the modalities of that, right? So again, anonymization is a big plus compared to the offline group work, and the diversity of narratives. You can really bring together a large range of narratives for the same condition and let them explore their stories and their experiences. There are obviously limitations. Unsupervised communities are dangerous, right? And and we strongly recommend against them right now. And also looking at, there's a lot of misinformation that can be spread, and that can lead to harm rather than good. So supervised communities that are anonymized is right now the way to go with communities essentially, and peer support. Right? Again, evidence is starting to build up. Again, not fully there, but we can see green shoots of evidence starting to build up, saying that actually adding peer support to treatment as usual can be more beneficial. Right? So it's still early days. The next basis, this is where it starts getting really interesting, right? From every aspect, from an outcomes perspective, from a science perspective, from a technology perspective, as we move from technology being an enabler to technology doing part of the work, the story becomes really interesting. And Peer Therapeutics, which runs an app called Reset-O, which and Reset, the two platforms they most popularly learn in the US, and Meru Health, which really looks at heart rate variability as an addendum to providing therapy, are two areas where the idea of digital therapeutics, of delivering evidence-based therapeutic interventions to patients, they're driven by software, right? So they basically, as an example, what Peer Therapeutics does is it is a technology-delivered program that is prescribed by addiction specialists in the US to those suffering from opioid addiction predominantly, right? And what they've gone on to show and got FDA approval for is that the outcomes for Reset-O plus treatment as usual is better than just treatment as usual. The retention in the treatment, the abstinence rates, they've looked at number of parameters, and that's why they're now being prescribed in the US. They're sort of there's reimbursement on insurance and all sorts of things. It's a highly valuable company also. It has become a very, very valuable company in the US. So again, for something like digital therapeutics, the evidence base is definitely sort of a higher bar than some of the other technologies that I'm talking about. And it leads to increased adherence to more conventional therapies. People stick to therapy longer. The challenge is because it's not distributed directly to the end user, the patient, the client. Therefore, the adoption has to be through physicians. So these are typically prescribed. So that can sort of slow down. And there's a higher bar along to get to insurance and payer reimbursement. But again, this is really the gold standard that all technology companies and all healthcare companies are striving towards in different specialties in medicine. So just to put it in context, this is where the largest amount of funding is going to right now. in the technology space, right? So for digital therapeutics, look, and again, as I mentioned, again, Pierre's got a FDA-approved program. It's undergoing clinical trial right now. So again, the body of evidence base is building up in this space, and probably faster than all the other spaces I'm talking about. Again, talking about augmented reality as the fourth model of care, it's a fascinating experience. So I've been to the Oxford VR offices in London and Oxford and experienced some of the programs they have and how they work, and it's really complex program technology that they've really simplified for the user, right? And they were really working on some phobias and graded exposure therapy, and that's how they're working. But now they're working on other programs using virtual reality as well. So that's the next technology that's being used. And again, advantages that you can now do exposure in a safe control setting rather than taking the client to that physical setting, and you can really standardize the grid and really create gradation as you do exposure. The limitations are there is if it's used for self-use, which is also being promoted for in some settings, then the clinical monitoring is missing, and the device the setup is still clunky. It's not portable. Cost is still high, so it's still a while away from getting to the point of being portability. And again, they're published in the Lancet. They've got good evidence base behind them. So really, again, looking at the evidence base building up in this space as well. And the one last two pieces I'm going to talk about is really the AI ML based predictive support, right? There's really predicting using passive data, whether it's language, whether it's how you use your mobile phone, what clicks you do, what taps you do, and really analyzing the data, benchmarking and validating against standardized tools, and then providing it to your clinician so that there can be better monitoring of your condition rather than just self-reported monitoring. And therefore, that can lead to better outcomes, that need to level up prevention. Mindstrong is the big name in this space, right? And obviously, the advantages are that this is a collaborative setup, right? Unlike some of the others we talked about, this is human intervention working hand in hand with really advanced AI-delivered technology. The limitations really are there are significant privacy concerns still, right? Because now this is gathering your passive data. So unlike teletherapy, where you are telling a therapist something in a clinical setting, this, like Mindstrong, gathers passive data from your mobile phone user. They don't typically take what you type in, but how often do you use your phone? How do you type? How do you swipe? Those are things that really use as inputs. And again, if databases are not and datasets are not divergent and diverse enough, then it can lead to inherent bias. And this is a problem with AI in general right now, right? If it's very predominant Western data sets that people are developing technology on, then it doesn't take into account a lot of the other parts of the world and other demographics and other sort of groups and how their behavior might be in certain conditions. So that's the other limitation of AI/ML-based programs. Again, a lot of evidence they've got 4 patents. Mindstrong got 4 patents. They've built some strong correlations to gold standard neuropsychological assessments for the tools. So again, this is not just fancy science as it would have been 10 years ago, but now they're really building the evidence base behind it. And the last piece is around self-help. Now, this is the space area that's really exploded, right? This is really targeting the client group that would never really come to us in clinic ever, right? Or at least at the stage that we see them. And so a lot of players in this space, lot of users in this space. The 2 big players, Calm and Headspace, are now on nearly billion-dollar companies. And they're really using mindfulness, sometimes CBT, sometimes meditation as a range of companies to really provide self-care tools for people at early, mild to moderate stages of common mental illness, essentially. So this is the last group. This is a place where more research and validation is definitely required. Yet. There is still a lot of work to be done from building a scientific body of evidence here. It's not effective for all conditions, but it's really good for introducing people gently to various mental health models of care, right? Where somebody would be worried about stigma, whether it's self-stigma or group stigma. This is really good as a tool to really introduce people. For some people, it's sufficient as well when they're subsyndromal, and that can provide support along with other models of care, essentially, as an adjunct, essentially. So I think I'm just going to, and again, Headspace has now got a number of trials in motion to build a body of evidence there as well. So I think the point I would make, and I think I'm out of time, and then stop, is really that the technology plays now really in full force. And I think it's really critical that we leverage it address the treatment gap globally, right? Because whilst we are short of mental professionals here in India, there are parts of the world that are even much worse, right? If you go to sub-Saharan Africa, for example, there are hardly any psychiatrists, right? So technology has to be leveraged. The evidence base is growing. I think we should really work collaboratively with technology players and help them and work and really build out the evidence base, not just for the efficacy, but also for risks, also for side effects. So we really understand the pros and cons of technology and really see how it can be effectively and seamlessly integrated with mainstream services, right? Rather than technology sitting there and us sitting here, how can we work together for what's required for the end user, the patient, the client? I'm going to just stop there and take questions, but the sense was just to give you an overview of the various themes that are developing in this space. But let me just stop there now.
Thank you, Dr. Amit Malik, for giving a great overview of all the wonderful opportunities that technology offers to improve psychotherapeutic practice. So we'll take the questions related to your talk towards the end of the session. So I would now introduce the next speaker. It's my pleasure to introduce Dr. Arun Kandaswamy. He is an additional professor of psychiatry at the National Institute of Mental Health and Neurosciences. He has authored many journal articles and book chapters. He is the recipient of the Tilak Venkobarao Gold Medal in Psychiatry, and he is also a fellow of the Ramchandra N. Murthy Foundation for Mental Health and Neurosciences. Dr. Arun would be talking to us on telepsychotherapy. Over to you, Arun.
Thank you, sir. My talk will be very specific in relation to the telepsychotherapy in psychiatry training program. This is in continuation with the talk which Dr. Murli had given yesterday to start with. It's about the psychotherapy training program in psychiatry residency training program. And we need a certain number of hours of supervised therapy sessions needed for a completion of the course itself. Now, Dr. Amit had clearly put in how the technology has advanced over a period of time. And we also are realizing that significant demand is there for telepsychotherapy in the clinical practice too. In view of that, we were thinking of innovating in our own training program also. And COVID-19 pandemic had pushed to an extent the need to inculcate psychotherapy training program, telepsychotherapy in the psychotherapy training program. Briefly see what are the opportunities over here. Definitely the ease of access to some of the highly sophisticated intervention is something is very significant. There's no geographical and travel constraints has helped to reduce the number of no-shows, which is one of the reasons why residents are not able to complete the number of therapy sessions, the supervised therapy sessions per se. So this will allow residents to do more psychotherapy sessions. By then, a better skill building also will happen. Again, in terms of supervision, the supervisors will be able to teach better with a video recorded session. And also this will help a quality check in terms of what kind of intervention has been provided by the resident to the client. Now, this will be a training in sync with the demands of the community too. The challenges are multi. One of the major issues about psychotherapy is boundary, and the boundary issues is significant over here also. For example, the presence of both the clinician, the therapist, and the client in the social media space also is going to be an issue. Now, when we are contacting through online platform, other online platforms are easily explored, and there are boundary issues which can easily come up over there. Again, skill building, one for the trainees, another for the supervisors themselves. The supervisors also need to learn how to do online psychotherapy sessions. Based on their learning, they will have to train for the residents. And the residents themselves are getting trained in various basic skills in psychotherapy. Now they have had to add the challenge of doing telepsychotherapy too. Legal implications, again, these are not very specific for the training program per se, but it's in general, there are legal implications for telepsychotherapies there. there is a significant issue in terms of the safety of the online platform used and also the data which comes up, where it is getting stored, the video recordings, what do we do with that, and what kind of records need to be maintained. These are challenges, and also issues related to internet, which need not be explained. Now, one last but not the least issue is about the need for such kind of technologically advanced exercises. We are going to exclude a certain segment of clients who will not be able to have that sophisticated ability to do this therapy or undergo this therapy. So what did we do in the Department of Psychiatry is that the Psychotherapy Coordination Committee formed a framework on recommendations for telepsychotherapy to be included into the training program. It's still in the formative stage. I would like to present some of the framework recommendations which we have made. The recommendation is that first 6 months of psychotherapy training, only in-person psychotherapy should be done. And after the 6 months, based on the supervisor's decision, whether the resident will be able to take up a telepsychotherapy session, the decision to allow the resident to do telepsychotherapy can be made, and that should be in a designated place and in a designated time, which is allocated by the Department of Psychiatry. And then the telepsychotherapy outside the location should be restricted to some of the senior group of residents only. Again, basic skills training. This is a part and parcel of psychotherapy training program itself in terms of using body language, non-verbal gestures, helpful responses, and dealing with difficult emotions. These needs to include these challenges in the psychotherapy too. As we have discussed yesterday, in our setting, there are 75 hours of supervised therapy session are needed for the completion of psychotherapy. Now, that could be modified as 40 hours of in-person psychotherapy and 60 hours of telepsychotherapy could be, this is what the suggestion which we had given. Record keeping, we shouldn't waive off any form of record keeping just because video is available. The intake, the session reporting forms, and the summary forms should be maintained as it is how it was earlier. What will be the procedure of therapy? The treating clinician who's going to refer the case for telepsychotherapy should be, or psychotherapy should be consenting for telepsychotherapy, and the client also should know and agree to the telepsychotherapy. The therapist and the supervisor should be comfortable in undergoing that also. And the client should have a completed diagnostic workup even before taking up telepsychotherapy. At the first few sessions should be in person, and the supervisors can decide based on the client's needs and the therapist's skills whether subsequent sessions could be telepsychotherapy or based on in-person psychotherapy. In what medium the telepsychotherapy should be delivered? Secured video conferencing software, which is interactional, which has an interactional way of communication, also being licensed for use in the hospital clinical services, should be used. Now, who should be undergoing telepsychotherapy? The people, it's again at the discretion of the clinician and the therapist, but a few people may be included. Those who have undergone full psychotherapy already and they need booster sessions, they are good candidates for undergoing telepsychotherapy. People who have undergone the intakes and initial in-person therapy sessions are not able to come to the setting because of various reasons, various logistic reasons. They could be included into the telepsychotherapy sessions. People who have mobility issues, elderly clients, clients with physical disabilities, they could be considered for telepsychotherapy as such. Like, who will not be suitable? Again, this is going to be at the discretion of the clinician and therapist, but there are certain groups we should avoid in general. One is those who have been identified to have boundary issues, otherwise also should not be a part of telepsychotherapy. It's going to be a little difficult. Those who are found to have active risk of suicide, self-harm, and harm to others, and those who seem to come in the substance intoxication state during the sessions, they need to be avoided for telepsychotherapy. And crisis intervention is best done in person rather than telepsychotherapy sessions. What are the legal concerns? They're not specific for training alone. It's generally for telepsychotherapy itself. Disclosure of sensitive information in a video mode is going to be an issue, which includes CSA or domestic violence or suicide or homicidal ideas. This is an issue which needs to be sorted out. Security of the video conferencing software and the data storage. By data storage, I mean, if the resident does the training, are they going to do it in their own systems, their own gadgets, or they're going to do it with something provided by the hospital? That needs to be determined before going into telepsychotherapy, because these data need to be secured and they need to be available for access to any court of law in the future if there is some cases coming up. What are the ethical and process-related issues? Issues of confidentiality, both from the psychiatrist side and the client side. Because what we are going to see is what the camera can show us. Beyond the camera's space, who's going to sit over there and how we are going to monitor confidentiality is going to be an issue that needs to be taken care of. The decorum and sanctity of the psychotherapeutic space is also very important, because we know in online sessions these days what kind of videos we get to visualize. So really that needs to be discussed even before getting into telepsychotherapy, what kind of decorum in terms of dressing or setting, what needs to be therein. Neither the client nor the therapist should record sessions without a prior consent. This needs to be discussed prior hand. It is good to develop and document a clear plan for crisis situations and emergency situations, how that will be handled. If it's not done, then there will odd hours and odd times, there will be an expectation to do online therapy sessions, which are going to be difficult for the therapist too. To summarize, we all understand that telepsychotherapy is a way forward, but utilizing the telepsychotherapy in the psychiatry training program needs careful planning and evaluation. In general, it is better to initiate in-person therapy and then convert to telepsychotherapy. And it should be acceptable to everybody involved, the client, the therapist, the supervisor, and the treating clinician. All of them should agree to the same. And I would like to acknowledge the contribution of the Psychotherapy Coordination Committee, which had put together all the document, and also the faculty who had given points adding on to changing some of the recommendations we have made. Thank you.
Thank you, Dr. Arun, for giving an overall framework for implementing telepsychotherapy and the telepsychotherapy supervisory program. I'm sure this would be of great use for many academic settings across the country and elsewhere. Okay, so I think we have had two very interesting talks. We've had lots of comments and questions. I'm going to, in the interest of time, because we just have about 5 minutes, in the interest of time, I'm going to sort of collate various questions topic-wise and probably request the speakers to respond. The first topic is related to the virtual reality modules and its availability in India. Dr. Malik, would you be able to respond whether these VR modules are available in India? What are the challenges in implementing such novel interventions online in a country like India? Are there any specific skills that are required for implementation of this? What are the technological requirements? And finally, do you think that in the years to come, especially with the boost that COVID-19 has given to tele-interventions, do you think these technological approaches would finally supplant the conventional face-to-face psychotherapy interventions? So just as a quick recap, VR virtual reality modules availability in India and the practical issues regarding implementation and specific skills that are required, and your opinion about the future of such interventions vis-a-vis the conventional psychotherapy approaches.
Sure. I mean, the first one is I don't think it's available in India right now, right? And the biggest practical consideration is cost and size, right? So right now it's a clunky equipment. If you go to the lab, it's really a full room of equipment in India, and so this requires a setup. But that I know. I mean, I haven't spoken to them for a year. I know they were trying to make it portable so that it could be put in a clinical setting. So hopefully, when that happens, that could be brought here. And so that's the biggest practical consideration, I think, is cost and portability as far as the VR setup is concerned. The other consideration that we must take into account is cultural sensitivity, right? Because this has really been developed and standardized on a specific population group. So I think if and when we start using these interventions at scale in different populations, especially in a country like India, we should really look at culturally validating the tools and implementing them there. I think the last question is a very interesting one. Do I think that technology will supplant psychotherapy? And I'll take two parts to the answer, right? One is the clinical answer and one is the technology answer. The clinical answer is no. It's as simple as that, because for as you go up the spectrum of severity for conditions, right, the degree of personalization and intervention, human intervention required will be very, very hard for technology to replicate. And I don't think that will ever change. Also, in certain conditions and certain situations, human intervention will be required for a very long time, foreseeable future, right? So in the last talk, we heard a few of those, especially around risk, especially around crisis situations, people with psychosis. I think we are still a while away from replacing human intervention, especially professional human intervention. I think the technological answer is that the big question that I often get asked is whether AI will be able to replace therapy, right? And I'm pretty confident that we are a long way away from that. And the technical answer to that is the diversity of data that exists in each conversation from the same psychological condition. What I mean by that is your conversation for a depressed client will be very different to my conversation with the same depressed client, and the conversation for different depressed clients will be very different, which is very different to what happens with AI typically today when it's used for customer service in a bank. And the combination very similar. So the data is so diverse that to apply NLP and to get that to train a machine to have a full conversation in that depth and personalization. I mean, I've talked to data scientists all over the world. We are about 5 to 10 years away from even scratching the surface of that. So both from a clinical and technological perspective, I don't think we are being replaced anytime soon.
Thank you, Dr. Malik, for that response. So let's move on to the next set of questions, which I've collated into one overall theme. And I would request Dr. Arun to respond to this. So what are the challenges that one might encounter, and what are the precautions that one would want to keep in mind when dealing with patients who might be acutely suicidal or acutely agitated? A second related aspect is about handling children and adolescents. What are the precautions that one needs to take? Would you want a parent or a guardian to be near to the child during the therapy session? So what are the overall guidelines that you would suggest in handling special circumstances in telepsychotherapy? Dr. Arun, over to you.
So the first question is about the suicidal and aggressive patients in the telepsychotherapy sessions. Am I right, sir?
Yes. And then the next is about children and adolescents.
It's going to be very, very difficult in terms of suicidal and aggressive patients. We are going to handle in online sessions per se. I don't think so. These patients should be taken up for online psychotherapy sessions. Maybe at that point of time, if in the session they are turning up aggressive, and ideally we should have another contact number. We can contact the relatives and tell them, terminate the therapy, tell the family members to bring them to the treatment setting would be the better option rather than taking it up telepsychotherapy. These are not patients ideal for telepsychotherapy. The second question about adolescents and children, this is a serious issue because obviously some of this are there even with our real life situation also. Some of the time parents want to sit or post session the parents want to know what's the discussion which has happened between the therapist and the child per se. Now this is going to be this is what I said about this the confidentiality, how much we can ensure confidentiality in such situations where at least adults would say that, no, you cannot sit along with me, but children doesn't have the ability to tell the parents not to be around. This is a serious issue. Maybe this needs to be discussed prior hand with the primary caregivers about what are we intending to do as a therapy with the client, and for what reasons we will divulge the informations beyond what the privileged communications. This needs to be discussed prior hand so that to sort out some of this issue after the therapy gets started. There's no easy answers in terms of how it's going to be different. The only way is discuss upfront that these are the things which we can do, these are the things which we will not be able to do, and it's the choice of the parent and the child to undergo the therapy sessions per se.
Thank you, Dr. Arun. I think, these issues related to, the therapist's duty to warn or to protect, especially protect the client or even others, relatives, especially when the client expresses suicidal and even homicidal impulses during the psychotherapy session are important issues. I think at this point in time, telepsychotherapy is in a pretty early stage in our country. And as we move along, there would be rules and regulations which would be framed in relation to these kind of challenges that we encounter. I'm sure there are rules governing such issues in the US and in Europe related to the duty of the psychotherapist to protect and warn in such situations. I think some of those may have to be also integrated into our rules. So now, for want of time, I would just read out a comment by Dr. Matthew Verghese and then end up with one final theme, hopefully in the next 2 or 3 minutes. So Dr. Matthew has a suggestion to you, Dr. Arun, for teletherapy training. Rather than 6 months, it may be better to stipulate that the student finishes some basic modules plus conduct about 30 hours of supervised in-person therapy. So we move on to a final issue, which is a very important issue, which is related to privacy protection. How robust are privacy protections when different countries have different or no laws governing data privacy? How do we foster trust when there are consequences people fear, such as, especially in the West, an increase in insurance premium based on data collected by aggregators? I would like both of you to respond to this, and then maybe I think we'll have an Indian perspective from Dr. Arun and also a UK perspective from Dr. Malik, and then we'll wind up the session.
Sure, I can take a crack at it first. I think there are two parts to that, right? One is really around what standards are you applying to any provision, and I think right now, if I look at from a global perspective on data protection, HIPAA and GDPR are the two sort of standards that are getting applied in two large parts of the world, and so if you're really going to build a service that's going to be credible from a confidentiality perspective digitally, you need to at least meet those standards, right? Then there are other things like ISO 27001 and other sort of standards you can apply beyond that. So the first thing to say is getting standard criteria that are globally recognized for data protection and applying them to your service and your technology is very, very important. I think the second thing is around, so there are two, when it comes to confidentiality, there's 2 or 3 parts to it. One is how are you conducting the session, or how are you conducting the interaction? It could be a session, it could be other interactions. How and where are you storing the data, right? And are you recording things that are and then how are you storing those? I think all three are very, very important considerations. I think, and there are now globally acceptable standards for all those things that we should really follow at every service. The last part is around the question about insurance, right? And what is very, very important from a clinician perspective, I think, from a user perspective and a patient perspective, is that the consent is fully informed, right? That you're not hiding the consent in the small print of your terms and conditions, right? So if, as an example, if you're going to, the simple thing is don't share any data with anybody unless there are clinical risks. Don't share with anybody as long as the patient doesn't consent. Now, if the contracting is coming from the payer is an insurance provider, then that information should be given to the user perspective. If the payer is an employer, then that information that actually, listen, we are being paid by your employer, we will provide summary of this interaction and the diagnostic data or the treatment data to the employer. Then the user needs to know that before they start interacting with you in the intervention. And that should be made very, very explicit right at the time of the initial consent and engagement, because then because for me, that's an issue of informed consent. That's a clinical imperative rather than anything else. That's, I think, following those standards is very, very important.
Thank you, Dr. Malik. The Indian perspective from Dr. Arun.
I feel that there are not much statutes available for guiding us in doing these sessions at this point of time. So it would be good for us to have a good clinical practice in terms of explaining what is the mode in which we are going to deliver service and what are the risks available. Because I as per my discussion with some of the people, there is no end-to-end encrypted video services or the softwares which can do interactive communications per se. Even I'm hearing these days, even Zoom doesn't have that end-to-end encrypted communications available. So in view of all these things, it would be better to inform people who are going to undergo this therapy and take their consent. That will help in avoiding some of the stresses which are going to come in the future. I'm sure as time goes on, there will be clear-cut statutes and guidelines will come up, what kind of softwares need to be used and what kind of data protection policies to be put in will be coming in the country. Until then, I think we should have our own good clinical practice, and documenting those good clinical practice is going to be more, will be the safeguarding for us.
Yeah, I think those are important challenges. Of course, the lack of the secure platforms which we can use for on telepsychotherapy is indeed a major challenge. But then, of course, we can still do certain good practices at our end. For example, if you're storing patient-related data on, let's say, our laptops or mobile phones, making sure that they're always password protected, maybe folders being protected with passwords now, because you might be doing something online on your laptop, but then, of course, now with the iOS and Google syncing everything across all the devices that you are having, that you are using, so many of those would find their way into your mobile phones, and so making sure that the devices that you're using for professional work are kept safe and secure, and others do not have easy access to the contents. So I think we have had a very interesting and informative session. I thank Dr. Amit Malik and Dr. Arun Kandaswamy for the great presentations, and thank you, organizers, for giving me this opportunity to chair the session. Thank you.
Thank you very much, and I'll just hand it over to Dr. Suhas to take us forward to the next final session.
Thank you, Dr. Jain. With this, we now come to the final session of this Nimhans Tavistock conference, and that is the panel discussion. I'm sure we have had a lot of exciting themes being discussed over the past 2 days, and several of you have responded with your queries, and at times it became difficult for the moderators to regulate the amount of good questions that were coming in to be posted to the experts who were actually giving the talks. So now we have an august panel with us, and to take this panel discussion forward, may I invite Dr. Vijay, who is the Associate Professor of Psychiatry at Nimhans, to introduce the speakers in the panel and to take it forward, please.
Good afternoon to all of you, and it's my pleasure to introduce the chairperson as well as the panelists for this panel discussion. To begin with, the chairperson, Dr. Pratima Murthy. She is the Professor and Head, Department of Psychiatry, and she was former chair of the psychotherapy program at Nimhans, with the diverse areas of interest including addiction, history of psychiatry, and psychiatric training. She is the recipient of many awards, including the prestigious Dr. Raja Ramanna State Award for Scientists recently. Next panelist, one of our panelists is Dr. Shobha Srinath. She is the consultant child and adolescent psychiatrist, retired senior professor, former head of the Department of Psychiatry as well as Department of Child and Adolescent Psychiatry at Nimhans. She was quite instrumental in setting up major child and adolescent psychiatry clinical services as well as the training facility at Nimhans in Bangalore, with the areas of interest including childhood autism, childhood obsessive compulsive disorder, as well as affective disorders. Dr. Julian Stern, I think he spoke in the previous session. He was a former head and the consultant psychiatrist in psychotherapy in the two prestigious institutes, with primarily the area of interest including application of psychoanalytical thinking for medical conditions as well as medically unexplained symptoms. Dr. Ashlesha Bagadia, she's a perinatal psychiatrist and psychotherapist. She's working in the Green Oak Initiative, which is the community mental health center in Bangalore. And she has very diverse areas of interest in primarily, although it focuses on perinatal psychiatry. She also is familiar with many of the psychotherapeutic techniques, including group therapy and mentalization-based treatment, as well as systemic family therapy, and including the mental health of the healthcare professionals. Now, moving on to the last member of our panel, Dr. Joan Stubley. She is a medical psychotherapist and a psychoanalyst at Tavistock and Postman NHS Trust. She is primarily trained in trauma-focused cognitive behavior therapy, as well as high movement desensitization and reprocessing, as well as MDMA-assisted psychotherapy for PTSD, with the areas of interest including primarily on trauma, in addition to historical child sexual abuse, as well as complex trauma and refugees. So, with all these panelists and the chairperson, we are looking ahead for an exciting panel discussion, and I request Madam to take it over from there.
Thank you very much, Vijay. Welcome you all to this very exciting panel. It's nice at the end of 2 half days to end with this very, very distinguished panel. And I'm sure there will be a lot of food for thought, over what we've heard of over the last 2 days and what emanates from the panel discussion. Just in terms of starting off and making a few introductory comments, I know that this was supposed to be an in-person conference. And of course, thanks to COVID, we've now used technology, something that we discussed in the last session, to actually have this conference happen. And I think I must place on record the idea that was mooted by Professor Dinesh Bugra and for Dr. Murli and his team to have taken this forward. And it's very exciting to see that this interest in psychotherapy is kind of rekindled and strengthened. That's a program that's been running at our institution for several decades. And it's particularly exciting for me as the former psychotherapy chair to actually see that this is now happening and that we're going to take it forward. It's also very interesting that psychotherapy has again, come into the forefront, particularly with COVID. I know, for example, that Viktor Frankl's book, Man's Search for Meaning, has become so relevant in today's world. And perhaps that's another, context in which we need to explore the potential of psychotherapy to help people along. I know there's going to be a lot of questions already that we have from the participants, but certain questions actually came to mind. And I hope at some stage in this panel, we would allude to some of these questions. The questions that emanated, in my mind at least, from yesterday's discussion of whether psychotherapy should be cathartic, healing, or both. Is it a mental influence, and how much is the personality of the psychiatrist relevant in this collaborative approach? Is it worth pursuing specific schools of psychotherapy, or should we be looking at eclectic models of psychotherapy? How can psychotherapy take advantage of the brain's neuroplasticity and the ability of humans for enduring change? And of course, considering the growing limitations of the boundaries of organic managements, we know that psychotherapy has a role. So how can we actually use this to the advantage of the person? The competing positions of medicine and psychological management have now given way to a more complementary use of both these approaches, and that's been highlighted again. The excitement of using technology and the challenges of using technology. And finally, I think really looking at a synthesis, we should neither be looking, in the words of Eisenberg, either at brainless psychiatry or mindless medicine. So I think this is a very, very important panel discussion. Therefore, we've already had an introduction to the panelists. I just hope the panelists are going to pop up on our screen so that we can see all of them, because we don't have any slides to present. So without any further interventions from my end, I'm going to ask each panelist one round of questions. I'm going to start off with our participants from Tavistock. My first question to Professor Julian Stern. And it was fascinating listening to you about, the kind of work that you do. Let me start off by asking you to share your experience of training psychiatric, medical, as well as nursing staff in applying psychoanalytical thinking in medical settings. What have been the challenges that you've experienced, Professor Stern, and indeed, what have been the advantages of doing that? You'll have to unmute yourself.
Thank you very much, and I would echo your description of what a nice and collaborative meeting it's been so far. I've thoroughly enjoyed it, and I was talking to Joe Stubley last night and saying that I actually, it's sort of bringing forward a wistful regret that that we couldn't all be in Bangalore, because of course a remote conference does provide a lot, but it doesn't allow for the sort of corridor discussions and also the sense of the room, the feeling of the situation that one can only really pick up when one is present. And of course that then links with perhaps differences between psychotherapy in the room with somebody and psychotherapy remotely. What one misses out on are some of those intangibles, the sense of what it's like to be in the room with someone, both as the patient and as the therapist, the silences, the body language, the other sensory inputs, whether it's smell, visual, auditory, or so on, which one has in a very two-dimensional way when one is working on the telephone or on Zoom, as opposed to a more three-dimensional experience when one is in the room with someone. Having said so, I've been delighted to be here today and yesterday, and once again, thank you very much to the organizers. Now, I always think about case material, and in response to your question, I want to go back to when I used to work in a hospital for colorectal and gastroenterological diseases, very closely with the doctors, nurses, and other paramedics. And frequently, there would be patients with irritable bowel in particular, but also other functional symptoms, especially relatively young women of the childbearing age, who the doctors would see or the specialist nurses would see. And the doctors would say to me repeatedly, Julian, we think that there is something going on here. And unless we have a psychologist or a psychotherapist available, we do not know, and they always use two phrases, whether to open up a Pandora's box or a can of worms. And they're almost always referring to their sense that there was some sexual abuse in the background, which was somehow relative to the patient's functional abdominal symptoms. And whenever I then spoke at conferences, I would get other doctors coming up to me and saying, we do not know whether to open up this discussion. We know that we almost can sense that there's been something traumatic or abusive or neglectful in the patient's background. But if we're working on our own with no psychological resources whatsoever and a 6-month waiting list to refer them to another service, do we or don't we open up this can of worms? Because if we do, we then have in our consulting room, and we're gastroenterologists, we have in our consulting room a patient who is starting to disclose that when she was 5 or 12 or 15, she was abused by a member of the family or by somebody else. She's generally going to be crying. She's generally going to spend longer than we have in our consulting room. What do? We're faced with a terrible dilemma. Do we actually know that we have this in the room and we don't address it? And then we could be replicating the sort of culture of silence and cover-up that, of course, such patients might well feel has absolutely characterized their childhood. Or do we open things up and then we're left with a crying patient who spends 40 minutes in the consulting room and we still don't know what to do with him or her at the end of the consultation? So I want to focus on this sort of dilemma, because if you are such a patient, where does this situation leave you if you're working, if you're presenting to a gastroenterologist or a general practitioner or a gynecologist, and the person, you think you're giving them clues and they don't pick up on those clues? Is that just a complete repetition of what you tried to do in childhood when you left clues around, when you thought you might have given a hint to your mother or to your school teacher, and they turned a blind eye to what was going on? So think of the patient and the dilemma that they're in. when you don't have psychological specialists, be it psychotherapists or psychologists, working closely with people working in acute medicine, be it in the hospitals or in primary care. Think of the dilemma also of the GP or the gastroenterologist. The sensitive ones are telling us that there's this Pandora's box, and they feel very, very torn as to whether to open it up or not. And then think of the dilemma of us as healthcare professionals, where we might want to work closely with GPs or other medical specialists, but where quite often, because of the hierarchy in medicine, when we do work closely with them, we're not necessarily afforded quite the same resources or quite the same respect or quite the same sort of decent consulting rooms or whatever that the other doctors might be afforded. And the tendency then to think, well, unless I'm treated well, I'm going to retreat to the psychiatric clinic and to my own colleagues. So I was just really bringing out this sort of case, first of all, because it happens often when one is working closely in primary care or secondary care. But secondly, because I think it helps to think about the perspectives, not only of the patient, but also of the physician or the surgeon, who, as I described in the earlier comments about the woman with the white discharge, might well have been driven to extreme and, in a psychoanalytic sense, rather hostile, aggressive, or even sadistic acting out without even knowing that that's what he was doing. So I think that the other thing that I want to mention is the advantage of having our trainees working at least some of the time in close proximity to general practice or to other doctors work and medical specialists working with patients with physical symptoms. All of us inhabit our own bodies. All of us have physical symptoms. All of us will get ill and will die someday. And there's been this, I think, very unhelpful split. People have mentioned sort of Descartes and dualism, but a very unhelpful split, certainly in the UK, where 30 or 40 years ago, mental health practitioners worked hand in hand in many situations in the acute medical hospitals. And then there was an organizational split, which split, in British terms, what are called acute medical trusts with mental health trusts. So that during the years of psychiatric training, if one chooses certain jobs, one might never go in to an acute medical hospital, and the medical doctors might never meet the psychiatrists who are treating their own patients. So you get two different specialists, one of them attending to the patient's head, one of them attending to the patient's body, and never the twain do meet. And that is unhelpful for the patient and can lead to really catastrophic results for the patient. So whatever is possible, I would encourage there to be as much professional intercourse between people working in acute medicine and those working with the minds of those same patients.
Thank you very much. I think that's a very, very important point that you're talking about, to reduce this dualism and, as physical symptoms as idioms of distress. I remember, Dr. Paulomi, who was chairing the previous session, was actually mentioning that we're talking about the symbolism and the migrating symptoms. I remember as an intern, and that continues to date, of many patients presenting to the emergency or to the outpatient departments with a lot of aches and pains. And when you actually spoke to them, it was their way of getting out of a house with so much responsibility and so much work that this was the only way they could actually get out and communicate with somebody outside the family. So I think encouraging a different specialist to look at this is indeed a very, very important thing. And thank you so much for highlighting that, Professor Stern. My next question is to Professor Joe Stubley. You said, you talked to us yesterday about the trauma clinic and the Tavistock trauma services. How do people actually use these services? What kind of movement occurs of people within and into the service?
Right. Thank you very much. And I want to start, first of all, by echoing Julian's sentiments. I think it is a great pity that we're not there in person, but I feel delighted and honoured to be a part of this panel. And I have so enjoyed these two half-day events. I guess I wanted to start as well by saying that I think that there is something really interesting that I've heard over these 2 days that I think strengthens the reality of the ubiquity of trauma. We started in, first of all, thinking about training and how important, I would say it is for in the training of psychiatrists and psychotherapists to have trauma in mind. We then moved to personality disorders, and we know that there is an enormous amount of trauma in the background of personality disorders. We see this from the adverse childhood experiences research. We then had a discussion about trauma, and I thought that Dr. Shaker's description of the healing-centered engagement is something that I really thought was beautiful. And for me, that also links in with one of these issues that Julian was just talking about, which is the various splits that have happened. And I'll come back to that in a moment. I also thought that it was really interesting to be talking about sort of digital psychotherapy. And of course, we've all had to struggle with this, learn a great deal of the positivity of it through this current pandemic. So I wanted to just say that, first of all, in relation to the conference, before I specifically turn to your question. I think, as I described yesterday, there is in our service the reality that many of our patients come, and although we are in general all trained in either psychoanalytic psychotherapy or psychoanalysis, our patients are often not ready for that kind of treatment, and some of them may never be. I was thinking about Julian's list of Glenn Gabbard's 11 criteria for psychotherapy. Most of our patients would never meet those. And I think that emphasizes the reality of one very important philosophy in our service, which is we attempt to meet the patient where they are. We are not trying to get patients to fit into our models, but to have a number of models that allow us to then step forward and meet them. And this is one of the reasons why flexibility is so central in the work that we do. And that flexibility includes different modalities. And we've heard over these 2 days, in a wide variety of ways, I think, a link to almost every kind of psychotherapy. We are slowly trying to increase that in our service. So as well as holding our psychoanalytic frame at all times, we have a number of different therapies at our disposal, which we see as tools for meeting the patient where they are. Now, I think the other aspect that might describe the kind of centrality of how we think about our patients is, again, coming back to this concern about the split between body and mind. The explosion of research in trauma over the last 25, 30 years, and particularly in complex and early relational trauma, tells us how artificial that split is. If someone has had early relational neglect, physical abuse, sexual abuse, it is going to impact on their minds and their bodies. And one, I think, very prime example is the cases that Julian has presented today. We know from research that people who have been traumatized are much more prone to develop the kind of immune and inflammatory diseases such as irritable bowel, chronic fatigue syndrome, myalgic encephalitis, fibromyalgia, and so on. There is a clear and growing link. And so part of the work that we do is to be offering things that are both attending to mind and body. And I was thinking about the last digital presentation. We are increasingly using the kind of digital well-being apps that were touched on, inviting patients to use relaxation techniques in order to bring their hyperarousal down. Not only attends to the psychoeducational aspects, but it also enables the patients to feel more empowered. And we know that disempowerment is a central aspect of traumatization. We also really focus on things like exercise, gardening, yoga. And I was thinking about that in terms of this issue that you were raising earlier about neuroplasticity. there's growing evidence that exercise and gardening, as two examples, both increase the production of brain-derived neurotrophic factor, BDNF, which encourages neuroplasticity. So it's a really interesting time, I think, where we're learning so much that challenges mind and body. I know I could talk much more because this is so important to me, but I'm really looking forward to further discussion in the panel. Thank you.
All right, great. Thank you very much. And I think you've kind of taken it further from not having that dualism to really being able to meet a person's needs and keeping it as simple and as pragmatic as possible to actually make change effective. Let me move on to Dr. Ashlesha Bagadia. You're doing something that is quite a difficult thing, which is really group therapy with persons who have personality disorders. And I'm sure it's been both challenging as well as exciting. So can you take us through some of the excitements and challenges of actually helping people in groups with personality disorders as the main theme?
Thank you. Thank you very much for inviting me to be part of this panel. I'm really honored, and if I must admit, a little nervous as well to be in this August panel. Just a little bit of my background. So I did complete my training in mentalization-based therapy. And I came back to India a few years ago, about 5 years ago now. And I guess my first challenge was just to try and, navigate the landscape of psychotherapy and psychiatric practice in India. I had only trained in, medicine here. So the first challenge I actually had was in trying to get a supervisor, because I didn't have anyone else who was trained in MBT, or even for me to try and think about how am I going to now start trying some of the skills that I've learned and try and adapt them in the clinical setting here. So initially, I only just worked with individual patients and was just seeing them individually. And then I realized my psychotherapy background is in family systems therapy. So I realized that my skills were better placed in a group and a systemic model. And I probably would be of more value to the individual therapist if I complemented their clinical practice with group therapy. So with that in mind, really, I started a group therapy program, which is primarily based with the MBT format. And it includes weekly group therapy sessions of 75 minutes each. And the patients are required to also continue with concurrent individual therapy and have regular psychiatric care and crisis planning. Now, the first challenge here was to try and integrate what I was trying to do along with all the varied individual therapy frameworks that each patient was presenting with, or their therapists were presenting with. And this is where I think, what we've been talking about a little bit earlier, is trying to be flexible, trying to adapt, not just where the patient is at, but where the system is at, where my colleagues are at in what I'm trying to do and how am I going to work with them. So that really was the starting point. I had a lot of challenges in finding a co-therapist, but I've been really lucky after initial few stumbling blocks. I had two brilliant psychologists who each helped me with the 2 cycles of group therapy that I was able to run. And so we've run now 2 batches of 1 year each, consecutive batches. And we had 7 members in the first batch and 6 members in the second batch. And I remember, I'd just like to quote an incident. The first group that we started, we had planned to keep it as an open group because just the idea of group therapy, and also because I was trying to do it in the private sector, to charge for it, to try and convince people to come and to pay me for me to do this therapy for them. So we had decided to start the first sort of round as an open group, and as it filled up, we would then close. So the first day of group therapy, I was supposed to have 3 patients, and then I had 2. And one of them very perceptively said to me, are you sure you know what you're doing? This looks very experimental. There are only 2 of us here. And I thought there'd be like a big group and I could hide behind, like a big group. So that was really useful. We were able to actually use that and talk about how she thought she could hide in a group and why that made her anxious to be just the 2 of them. But I to hand it to her, she was perceptive. She was right. It was experimental as far as I was concerned when I was starting off. But the outcomes that we did see for these 2 groups that we've run, and I know these are really small numbers and very early beginnings, but we were able to find some reduction in their self-harming, reduction in their suicidality, improvement in depressive symptoms, and also improvement in reflective functioning. And I think this was quite interesting finding, because it's something that's not very tangible, certainly something not the family members were able to sort of recognize and not very happy about, because they didn't see tangible results. But we hope that this would help them to sustain the other behavioral outcomes for much longer. Another thing that we tried to do during our group therapy program is to meet the family members every 6 weeks. So we meet the family members of the people who are part of the group and try to just talk to them about the disorders, the strategies they could try with their family members, and the kind of difficult emotions that come up for them as they're caring for their wards or their spouses. So these are some of the initial sort of challenges I faced. As a parallel to this, I also realized, and I think we heard from Dr. Jessica Yeckley yesterday, is that there is a lot of evidence that's coming out of specific therapies, but there's also a lot of good evidence to tell us that, just good basic clinical care is really important, and especially when we're dealing with personality disorders. So on a parallel, what we've been trying to do is hold workshops and upskill psychologists that we're working with, and talk about just good clinical care. How do you set boundaries? How do you stay within the boundaries? And how can we give consistency is something that's really, really hard when we're trying to navigate this world of isolated, practitioners working in isolation. And also collaboratively. I mean, one of the things that, and I'm so glad, I'm really grateful that this kind of collaboration is happening. And I'm hoping this means a lot of, good things for Tavistock and Nimhans, especially in terms of translating into training for all the people who are watching. Because one of the difficulties we've had is the kind of splits that are there between professional groups, and I think especially when we're dealing with people with personality disorders, there's enough splitting that comes from them as a psychopathology. So it's really important that we are not split from the beginning, and we can try and sustain that and tolerate it and take it along and not allow it to split us. So so these are the challenges we faced. And just before I end, I'd like to say that we've also had some training happening. Professor Bateman came last year and conducted the first mentalization-based training in India, and there's a lot of interest there. And I think even there we found that we probably need to go down to the grassroots level of understanding of all our skills, which might be very far away from, the clinic high-end MBT therapies that are there. So we are hoping that more of that training takes place. And so I'd like to stop there and further the discussion. Thank you.
Thank you very much. You picked up very, very important points. Isolation, not just patients feeling isolated, but the therapists or the health providers themselves feeling isolated in providing care. And the second thing was the splitting as a defense in the patients and, of course, in professionals, and the way, they need to come together to kind of help patients along. Finally, in terms of the opening remarks, let me come to Professor Shobha Srinath. Last but not least, she is my teacher in psychotherapy. I had the fortune of being in her psychotherapy supervision. And so many decades later, when my groupies get together, we discuss what Shobha might have said if we had this case to discuss in psychotherapy. So Shobha, to you, and you've been one of the pioneers in actually setting up the program at Nimhans, along with Professor Shamsundar, Professor Raghuram, and of course many other colleagues who still continue to be active in the area. And considering your role has been primarily with working with children, what is the role of the family, Shobha? And I think it was mentioned yesterday in terms of systemic therapies and involvement of the family in psychotherapeutic work with children, and what indeed are the challenges thereof.
Thank you. Like all the others have done. Am I audible? I would very much like to thank the organizers and also say that I have enjoyed listening to the speakers, especially to the speakers from Tavistock. Very, very interesting. The last 2 days have been. And as Professor Stern said, it's really sad that we all couldn't meet in person, but this is the next best. So I'm happy to be here and thank the organizers again. Now, Vivek spoke briefly about the family, and we know that in India, for us, the family is our asset. It's our biggest asset. And to a large extent, we think that our family members are usually often quasi-co-therapists for us. India being a place with very few mental health professionals, a lot of our work is done with the family so that the family helps us with the child or the adolescent. I will even go so far as to say a mentally ill adult in India has a much better chance with his family or her family than in many places outside this country. So I would think the family is a very, very important part for us. And we take a lot of effort to keep the parent or the spouse or the partner in the therapy in whatever fashion the patient wants or allows. So for us, our major aim is our patient, even if it's a child or an adolescent. And as you know, in adolescence, a lot of our young people have trouble with their parents. And they often are looking for who's taking whose side. And so the adolescent is very upset if there is the possibility that you're siding with the parent. So we often find that as a child is, of course, all of you know that as a child is younger, we get more support from the parent. And as the youngster grows, then we take less support. But we find that many parents in India with small families or an only child, very, very enmeshed, like Vivek said yesterday, very enmeshed, and very often want to know all the details. So oftentimes, if you haven't included the parent well, the parent feels that the child is moving away towards the therapist and is getting friendly. And if there are secrets, then all the more is the worry. So there's a great need not to let the parents sometimes sabotage what's happening with you. So it is necessary to have the family in. Oftentimes, we take efforts to talk to the young person. And I had a young person in therapy not so long ago. She was 18, and it was clear that there were significant attachment troubles with her parents. But she came saying she wants nothing to do with them. She wants to talk to me alone. We spent quite a bit of time until we reached a point, because I knew that if we didn't look after these attachment ruptures, she's going to continue to have trouble with all her relationships later on. We reached a stage where we were able to get the parents in, and she agreed that it would be good for me to coach her parents to learn how to handle her. So I felt that we had made great strides to that extent that the child actually learned to work with them and they learned to work with her. So I think when we have either a partner or adult children and parents, there's a great need to have note keeping and supervisor. No matter what the age of the therapist is, I think it's necessary that you must have some kind of a peer support or a supervisor. And there's a great need to keep notes, especially when you're having more than one or two people from the same family you're working with. So I would say that the need for note keeping is something that is very, very hard for young people, having supervised so many young people. And I know how difficult it is to keep notes myself. So I think that any training that happens, especially when more than one member is involved in therapy, the note keeping is absolutely important. It's important also to do your best for the patient, and notes help you in a great big way. So I think family's role is great in India. It will continue to be great. And we must see to it that we make use of that asset as much as we can.
Thanks, Shobha. Thank you for highlighting the importance of the family. And I think whether it's with children or with adolescents or indeed with adults, very often families become central. Before we take the audience questions, I just wanted both Julian, if I can call you Julian, and Joe to actually respond to this, to the a fairly pivotal role of the family in terms of therapy, and how do you engage families? You can go in, Julian first, and then Joe briefly.
Well, it very much depends on the context. If one is working in a situation where the therapy has been defined right from the start as individual therapy, then it is unlikely that one would literally include other family members. But I'm really talking about working primarily as an adult psychotherapist. And I think that if I was working in a child and adolescent department, my orientation would be extremely different. However, there are some occasions when one's working with an individual patient when one thinks, gosh, it really, really would be helpful to have this person's spouse or other family members in the room. And then one has to make a decision. Does one break with the sort of, as it were, the almost religious boundaries that one's working under, and invite a spouse into the room, which is not commonly done, especially in the more purest forms of psychotherapy? Or does one try and work out in one's own mind, what is it that is going on in my mind that makes me think that it would be helpful to have the spouse in the room? Is the patient projecting something into my mind? And one might then be able to work with that question of what's being projected, what is lacking, what is not being talked about, what does it feel can only be talked about between this couple, and help the patient realize that perhaps there are certain deficiencies or lacks that he or she can only deal with external to the therapeutic situation. But certainly, if I were working primarily as a child and family or child and adolescent psychotherapist, the bringing family members in, be it into individual sessions or, as one tends to as a child psychotherapist, ensuring that one has some sessions either with the parental couple, if it's a couple, or with parents and child, would be absolutely crucial. So even if I don't always bring family members absolutely into the room, the person's family setting, the context in which they've been brought up, the context in which they're currently living, is absolutely crucial to my way of working.
Thank you. Jo?
I guess there's also something for us, again, in the trauma service of a bit more flexibility. We do quite often have patients who either request that they're seen from the beginning with a family member, and for us, that's often around the issue of the trust that's been lost because of the traumatic events, and we would work with that over time. We also offer at times couple or family interventions. But I was also thinking that there might be something cultural here as well, because for many of our patients in the trauma service, the biggest problem is that there is no family involved, that their level of social isolation is so profound, partly because of the avoidance and numbing and shutting down that has occurred because of the traumatic experiences. But I think also something cultural about how many people find themselves in London coming from other places. And so much of our work is about trying to strengthen those social ties and connections and looking at externally what they can link in with and helping them do that. Sometimes that's about the beginnings of groups with us, of simply being in the room with other people can be so difficult that we work very hard on that. And of course, the pandemic has had a huge impact on this. I also just wanted to mention, because I think it's a very interesting link, that we are just about to set up our first trauma-based MBT group. And this, for me, comes after 25 or so years ago, training with Anthony Bateman when he was just kind of finalising his mentalisation-based therapy. So it feels really important. And I suspect that part of that work is also going to be very important in terms of looking at this issue around social connection and coming in again to the area around epistemic trust. You know, it's much more I could say, but I'll stop here.
It's just nice to see the connectedness in what you've been doing. That's really wonderful. I do know that we have a set of questions that our audience has asked us, and thanks to the audience for being so patient this far. So I'm going to have Dr. Vijay ask the questions. It will be directed to specific panelists. We'll see how many we can take in the next few minutes.
Yeah. Since we were discussing about the role of family, I think there is one question specifically being asked to Dr. Ashlesha. What are the difficulties you face while revealing the diagnosis of personality disorders to the family as well as the clients? Since it's normal, abnormal, that there is a gray zone, considering that one of the participants wants to know how do you deal in those situations?
Thank you. That's a really important question. And I think I'd like to put it in context of the Indian setting where, the whole concept of mental illness itself is stigmatized. At least Bangalore is very urban. So we are already seeing people with borderline personality disorder coming with the stigma, which is more, akin to what you might see in other countries as well. And one of the challenges definitely has been for, as a clinician, to make sure that I'm not blaming the parents, because that's where it goes first. And that's where the clients or the patients are also sort of saying, it's because my mom is like this, it's because my dad is like this. So on the one hand, and also another thing that's happening is, at least in the group that I saw, a lot of the patients, their therapy was being paid for by their parents, by their family members. So there is a little bit of buy-in to ensure that they get treatment, but also to keep the problem in the person rather than look at the system, look at the family. So I've tried to, in the spirit of MBT, I've tried to be as honest and genuine as possible, and to sort of say that, what we know is this matches a personality disorder that we know of. And I say things like, the problem might be in the person, but the solutions lie in the family. And also if you as a family or as a system are struggling, then you're not going to be able to help the caregiver as well. So can we look at what's going on in the family that can be addressed, as a system, what can we do? And like I said before, not just as a family, but as a team as well, as a unit, what we can do. And it's not been easy. We've had, different members of the family members. Like, for example, a dad would say, yes, I can see now, when my wife gets anxious, my daughter is a little bit more upset, and probably my wife needs to cool down a little bit. But, so you'll see one family member kind of getting it and the other one not getting it, and them not turning up for the family sessions that we have for them. So it's not easy. I think there are lots of challenges. But I think what we can do is just keep trying, and I'm hoping that changes the setting.
Considering these challenges, many participants are also interested to know, how do you retain patients with personality disorders in follow-up? Retaining them is also very difficult. Is there any specific tip you would like to give to the clinicians? The question many participants want to know.
So I do think the focus should be on retaining or kind of holding on. And I suppose what we've tried to do is, when they're in front of us, to try our best to understand them. And of course, we've lost a lot of, especially in the first, what we noticed in the two groups is the first kind of 2-3 months is like a chaotic period where they're getting used to it, not sure whether they're figuring out whether they're trusting us or not. And then in the first 3 months, it all settles down, and then they're starting to form a trust with us and with each other in the group setting. And what really helps is to, even when there are misunderstandings, to try those and understand those misunderstandings and not let them go. So that is something that helps, and not focus too much on trying to hold on to them, but when they are with us, to try our best to understand them. I think that's what we've tried to do.
So, Dr. Ashish, are you saying that you don't need to go an extra mile apart from what you're doing within the session to get the person to come back, or do you need to do anything else?
Well, actually, I do a lot of stuff in the sense that I think that in the initial contact with a lot of people with personality disorder, there's a lot of courting. There's getting them to understand the concept of group therapy. There's crisis planning to let them know that all of us are available at these set times. But beyond that, I mean, I think at the end of the day, if they're not going to turn up, it's not like we are going to penalize them or hold it against them. And if they don't come for so many group sessions and then they come back, is to still, give them the same care and attention when they've come back. So definitely there is a lot of extra effort put in the beginning in the engagement, but it's not with the idea of keeping them, but it's the idea of let's make every contact as meaningful as possible, and then hope that it kind of falls into place.
And keep the door open for them to come back.
Keep the door open, absolutely, yeah.
Thanks, Dr. Ashlesha. This particular question is directed to Dr. Shobha Srinath. Considering the Indian context, is respecting the autonomy of the patient impossible? At times it's difficult to draw boundaries between the individual and the family. So,
I think the therapist must be flexible and must take her cues from the client, from the patient, and work with that in mind. And the autonomy, the confidentiality, all these are things that the patient will know in the initial few sessions as to what kind of trustful, confidential, safe setting this is. And that is very important in order to get that initial engagement in. I feel that a lot of times the patient initially has in building this therapeutic alliance, that is where you would have listened yesterday and today. And by and large, everybody has spoken about the great value of this therapeutic alliance and how necessary it is for whatever form of therapy you do, that gets the engagement first. So I think it is at that time, in these early times when this is being formed, that the patient does understand. And if there are no violations, and if the patient or the client is your central person, and everything that you do is through that person after seeking permission, and the person knows that nothing that you do is going to harm them. There are sometimes very many young people who are very, very sensitive, very rejection sensitive. The therapist may have to take extra trouble to see that they make them feel safe and secure, and that their self-esteem is not hampered, or that nothing that you say makes them, belittles them. So some of these things are all happening right at the beginning. And I think with that, even when families come and ask, I had a girl who used to come and tell me, ma'am, you better tell my mother something. She thinks that you're keeping some secret from her that you and I discuss, because after every meeting, she will ask me, so what happened? So what did auntie say? What did doctor say? And whatever. And I usually, it puts my hackles up, and I don't tell her anything, even if I wish to tell her. So you better tell her something, because she's paying for my therapy, ma'am. And she very often will ask me, did you speak to my mother? Don't tell me what you spoke. You reassured her, isn't it? So I'm saying each of them, each member in this group will take pains to see that the best thing happens by and large. So it's a little tension. It's a bit of a tension for the therapist, but it should be possible if one is consciously aware of what each one is seeking from you.
Thanks, ma'am.
Okay.
Yes. I have a follow-up question. It's on therapeutic alliance, because we discussed about that when answering this current question. The question from the participant is there a divide between different schools of therapy on its significance or the way in which we would establish therapeutic alliance? For example, CBT versus psychodynamic therapy. Is there a difference in the significance given to this therapeutic alliance, as well as the way in which we would establish therapeutic alliance between different schools of therapy?
Joe, perhaps you could take that, Joe?
Thank you. It's a really interesting question, isn't it? I think there is a difference. I think that more traditional psychoanalytic psychotherapy would see that the engagement still has to be within the boundaries of the psychoanalytic style of working. And I think that would mean that many things that other therapies might do, and what other members of the panel have already been describing, would be felt to be seen as enactments of being pulled into doing, rather than keeping a more traditional role in which one is thinking about what's going on in the transference, trying to monitor one's own countertransference, and potentially, if it seems that the patient is able to be able to talk to the patient about that in ways of using transference interpretations. So I think that that's a very traditional model. I think that there are, though, and particularly in the settings that we work in, adaptations to that traditional model that recognise that there needs at times to be some ways in which one might be doing things that are seen, therefore, to be getting pulled into, but are also part of strengthening an alliance. And I guess from, again, the trauma perspective, we would see that attendance sometimes to external realities that might make it very difficult for a patient to engage in therapy, issues, for instance, around homelessness or financial difficulties. If these aren't engaged with by the therapeutic team, then that can also have an impact on the capacity to form an alliance with the patient. I also think that sometimes things around the psychoeducation aspects are also a strengthening of alliance, because it is about giving the patient some empowerment, but also an understanding of what's going on with them. And again, a more traditional approach might see that as an enactment. And I guess the other bit is that although we might be with some patients working more traditionally in a psychoanalytic way, we would often hold off on giving interpretations that are perhaps more negative transference kinds of interpretations. So picking up someone's aggression, for instance, or their destructiveness. is something that would be potentially very damaging to the development of an early therapeutic alliance for a patient who's been traumatized and who is already likely to be mistrustful and potentially have very persecutory anxieties. So there are different sort of stances that we might need to think about as well.
Thanks very much, Jo. I think there are a few more questions, but what I'm going to do is request that we use this as through email. We actually send it to you so that, we can then share it subsequently with the participants, because we are reaching the end of this panel discussion, and I'd like some other, areas to be addressed briefly by our panelists. So if that's okay, I hope that's okay with all our, all the participants, that we will, take each of your questions and make sure that the panelists answer your questions. But just in terms of winding up, let me ask Julian. Julian, what do you see the way forward for this Tavistock-Nimhans collaboration, and on a larger scale for psychotherapeutic training and strengthening in both our countries?
Well, that's a nice, easy question. Thank you. I think that this has been it's been a very, very good start. And especially given the fact that we've had to do it on Zoom with all of the issues relating to remote work, I think that my sense is that there's been a real sense of friendship and collaboration and mutual respect, which is a great beginning. I think that what we'll need to do is work out, both from each institution, what our respective wishes are and needs are, and then see whether we can come together and fulfill at least some of those needs and wishes. I think that undoubtedly it's going to be bi-directional. I think that there is a huge amount that we, and Joe's alluded to this, a huge amount that we can learn from our colleagues in Bangalore and in India, be it to do with your expertise in MBT, your expertise in thinking about culture, your expertise in thinking about remote ways of working, traumatized individuals, etc. And so I think that we need to know what you can offer, as well as you sort of needing to know what it is that the Tavistock might be able to offer. I think that the one thing that I could say is that I hope that our institution will be welcoming towards requests coming from Bangalore, with the proviso that we are all living in a world where resources are stretched, resources including time, money, and expertise. But there's a huge wish, I think, on our part for things to progress further. So thank you for helping organize this initially. And I hope that things continue for many, many years.
Thank you. That's a very, very positive, indication of further work, and this is only the beginning of that. Ashlija, are you aware of any other, any psychotherapy courses that are being run in country, that you could share with us? There's a question about that. Are you aware of anything
So I know that
psychiatrists?
I don't know if they're specific to psychiatrists. I know that there have been the traditional psychoanalytical training that the psychoanalytical school in Mumbai offers. It's to everyone. I think it's open to all. What we've been trying to do in Bangalore is just started a foundation course in psychodynamic psychotherapy. Again, that's open to everyone. And we just finished the first batch, and we had psychiatrists also enroll in that. And that also lends itself to a very adult learning model, which can, be incorporated into regular clinical practice, so that it doesn't involve enrolling full-time into a training program. And I think there are some programs in Calcutta and Delhi, but I'm not fully aware of the extent and who they're catering to.
I think the Ambedkar University in Delhi offers some courses, not to psychiatrists, of course, but I think there are courses in psychotherapy training. I think the
Delhi has an MPhil program on psychoanalytical psychotherapy, I think. But that is primarily aimed at psychologists, if I'm not mistaken.
Okay. Joe, I'm going to ask you a question and then ask you to respond to that as well. And my question was something that Julian mentioned before about the Pandora's box, or sweeping things under the carpet. And particularly since you work with adults who have a history of child sexual abuse, this is something that I think in yesterday's talk from Shekhar, we heard mentions about this. So what are your suggestions about how we can actually, take this forward in terms of both training and in terms of services?
Thank you. And the reason why I was getting excited there as well and putting my hand up is because I think it might also be important to say from the Tavistock perspective that one of the things that the pandemic has done is we have had to move our training all online. And although that's been quite a thing for us, I think it could be a really exciting development. So we run a 1 year, half day a week trauma course that we've run for 25 years at the Tavistock, primarily psychoanalytic, but bringing in many other aspects. It's now going to be a hybrid course where we will be taking people from overseas as well as having people in face-to-face when that's possible post-pandemic. And so I wanted to raise that because I think that there are going to be a number of those kinds of possibilities for people, which is really exciting. Your question about historical child sexual abuse, I mean, first of all, I'd say I think I need another whole lecture time to be able to answer that. There is no doubt that we in all of the world need to be thinking about how to address this. And one of the roles that I have taken up recently is as co-chair of an expert reference group for the Royal College of Psychiatrists, specifically to address how do we look at our training and our clinical services in relation to how we manage the question of historical child sexual abuse. And I thought Julian captured really well this dilemma of, do I open this up and am I going to be able to bear it if I open it up? But also the potential for enactment that we can all get into, which is better not to. And then we take up the role of the witness who is the denying other. So we have the repetition compulsion in action again, where there is a victim attempting to disclose and the denying other who turns a blind eye. And I think that this has been something that has been occurring for centuries in this area. And the fact that we are even having this conversation is trying to address something of that. So I think that there is something very basic that needs to go into training about how we look at really supporting people to be able to facilitate disclosure and not to turn away from it. And that needs to be across the spectrum of medical, psychological interventions. Again, it's a big topic, but I hope that at least kind of says something to your question.
I just wanted to flag that because I think each one of the topics that have been discussed make for an entire symposium on that particular topic. And I think we need to start recognizing which of these requires further dialogue. Finally, Shobha, from you, how do you think psychotherapy training in India needs to change to accommodate the changing needs of Indian patients?
Please unmute
your mic.
I'll start by picking up from where Murli left yesterday, which was he gave us a list of the number of colleges or universities which had training. And that's such a meager number where training in psychotherapy occurs. So we are talking about a large number of graduates in psychiatry, postgraduates in psychiatry, who get out as consultants who wouldn't have had any kind of training in psychotherapy. And that's the very sad thing. And I think Nimhans has been doing this for decades now. And I think Nimhans should, and along with Tavistock now, should have a program. And now because of this epidemic, online, and I think others can disagree, that supportive psychotherapy could be one start off. And when you say supportive psychotherapy, I know there is a lot of trouble about its theory, that from being theoretical, but when I say supportive psychotherapy, I'm talking about it as psychoanalytic based, psychodynamic based. That is, the person is thinking psychodynamically. You don't have to say all that you understand to your patient. You only do that much to support, but you have to give training, some minimal training to all postgraduates in psychiatry. And I believe Nimhans is best suited at this juncture to plan such a lowest common denominator kind of training, which initially, of course, can't even be hybrid because of the kind of situation we are in. It can practically be a lot of theory. So if you look at, there's a very good paper by a lady called Caroline Douglas in 2004 on teaching supportive psychotherapy to psychiatric residents. So I find that a lot of psychiatric residents don't get trained because many of them don't go to, there aren't any psychologists really in many medical colleges, so they cannot get any training there. Whatever training they get, they must get from their psychiatric mentors or supervisors. And if we say there isn't any training in the country, then the mentors themselves wouldn't have had much. So we are talking about the possibility of Nimhans having a kind of a program which probably is largely knowledge-based. It could have, we have 30 plus, I was surprised to hear we have 30 plus supervisors in the psychotherapy program now in Nimhans. So we could have a supervisor having virtual 6 students in a group on a platform, meet once a month or twice a month, and they could talk about what was the theory content with some kind of a role play at the supervisor's place or some material being brought at the last part of their training. I don't know, but to me it appears the supportive psychotherapy is a big possibility. It can be subscribed initially because you don't want to have large numbers, but you must be able to have students who are psychiatric residents who come in for such training. And I think that kind of a training is very, very feasible and Nimhans should be in a position to do it. So I feel very strongly about this. And I think, for example, the business of taking strengths and vulnerabilities of your patients. I find many residents, when they do work with their patients, hardly know of the patient's strengths. They've hardly known. I mean, how can you make the person feel better and support the person if you don't know what are the person's strengths? What's he good at? I mean, your patient is not your patient just because of that one part. He's a whole. And like Joe said, there are lots of things that the patient can be empowered with, and strengths, assets and liabilities, vulnerabilities and strengths, very basic things are not touched upon by residents. And I think it's largely because of a lack of training. They don't know what a support means. They don't know what does it mean to give advice, how much of advice to give, overwhelm the patient. So I think they need a lot of training, and even if it's at the knowledge level, we should be having some kind of a training. I wish to say that.
Thank you very much, Shobha. I mean, it's been a delight to listen to all of you touch so many different facets of psychotherapy in this very short time. And considering this, the title of this conference was Psychotherapy Across Epochs and Methods. I mean, the last 6 months has felt like an epoch. And I think we also looked at the challenges as well as the opportunities, particularly to help people with psychological methods. And I think it's actually become very, very relevant, that we need to bring people to deal with themselves and indeed to deal with communities and the others in a better form. So I think we've touched on all these things, and I do hope, and Shobha, you just reminded me of what I perceive as success in a psychotherapy training, when a trainee at the first, in the beginning of the psychotherapy supervision said, I'm a biological psychiatrist. I don't understand this, and I don't think it's of any use. But by the end of his 3 years, he said, I can apply many of these principles in helping my patients, and I've discovered I can do it better. So I think that's really been the essence for me of understanding that psychotherapy works. But I think all of you have actually highlighted the importance of getting psychiatric trainees, as indeed other specialists, to understand that addressing psychological distress, understanding person's strengths and vulnerabilities, and helping them along in adapting to themselves and indeed to the world around them are very, very important aspects of psychotherapy. Thank you all very much. We had some coffee, some very aromatic coffee, which unfortunately had to be virtual for all of you. I'd like to thank all the participants as well for a wonderful 2.5 days and of course to Vijay for moderating the session. And I hand it back to Arun to conclude this conference. Thank you very much. And to Suhas.
So we approach the finale of the inaugural Nimhans Tavistock Psychotherapy Conference. This conference involved over 6 months of planning 60 days of intense efforts and coordination, 6 hours of rich intellectual bonanza that discussed various themes across contexts and methods, bringing in expertise from across the globe involving 2 institutes with a rich legacy in psychiatry and psychotherapy. I now invite Dr. Arun Kandasamy, the organizing secretary of the Nimhans Tavistock Conference, to deliver the vote of thanks.
Thanks, Suhas. It's indeed a pleasure to give a thanks to such a collaboration as such. It's customary to thank everybody individually, but there are 2 big institutes coming together and trying to put up a good conference for all our people. That's something which, as a younger psychiatrist, I feel it's my it's my luck, or it's something which I had got at an early stage. Let's hope that this work continues and all of us will strive to continue this collaboration for a longer period of time. I would like to thank Professor B.N. Gangadhar, who's the director of our institute, for allowing us to host this conference from Nimhans. A special thanks to Dr. Dinesh Bugra, who's the linchpin in bringing the Tavistock to us in conducting this collaborative conference as such. Thanks to all the Tavistock administrators also for allowing this to happen. Specific thanks to all the UK speakers, Dr. Jessica Ackley, Dr. Joe Stabley, and Dr. Julian Stern, whom I had bothered a lot of time in terms of the sessions and the topics and other issues. Thank you very much, all of you. I would like to specifically convey my thanks to all the Indian speakers too. Most of them are my teachers and my colleagues, and also Dr. Amit Malik from Mumbai is someone whom I had got a new contact. And I thank all the chairpersons and moderators also for putting a good conference where we had a tight schedule. They were able to keep everything within the schedule per se. I would also like to thank the Psychotherapy Coordination Committee, which had helped me and the team to put up a good show on both the days. Again, the thanks to the Sunpharma, who were sponsored some of our activities for this conference. I think last but not the least, I would like to thank the audience who had joined in a larger number. There are 2,000 registrations, and we understand that many people will be able to come and go. We had at the peak, we had around 850 participants in the session, in the active session, which is a huge number. I thank all the audience who had made this demand for us. That another person I have not thanked is Professor Pratima Murthy, the head of the Department of Psychiatry and the chairperson for the panel discussion too. She has been my mentor and quite instrumental in taking the psychotherapy training program forward. With Madam's guidance, we will be able to carry it forward in better formats as such. And thanks to Dr. Murli, who is the chairperson of Psychotherapy Coordination Committee too.
Arun, I must just end with the Indian concept of the Guru Vandana. My Guru Vandana is to Shobha, and now we have a Guru Vandana to you. So I think what goes around comes around, and especially thank Dinesh for actually bringing this whole thing together.
Thanks, Dr. Dinesh.
Thank you very much, and have a wonderful weekend, everybody. Lots to think about, what we discussed at this. Bye-bye. Thank you.
Thank you all.
Thank you.
Have a good evening.
Bye-bye.
Bye, Dr. Dinesh.